Hello everyone. Uh, so right now we are going to start a longer session similar to what we did previously. So here we are going to have a timer and I am going to begin it right now. And what are we going to learn? So in the last video we finished this topic, intrauterine fetal demise. So next it is complicated pregnancy, and we'll see how far we can reach, because I have not planned this and I'm thinking of finishing up a big chunk of ops today during this particular session. So let's try it out and see how it's going to be like. Anyways, I'll begin it now. Yeah, so the first topic, RH isoimmunization. So we know from our previous classes what it means and overall what is the state of the maternal side as well as the fetal side. So let's just take a look what's there in OBG. Pregnancy in RH negative woman. Definition: RH negative pregnancy refers to the situation where woman with RH negative blood type carries a fetus that may have RH positive blood inherited from an RH positive father. This makes sense. Mom is negative, dad is RH positive, and the baby is RH positive. This mismatch can lead to maternal aluminization and hemolytic disease of the fetus and newborn, which is known as HDFN, hemolytic disease of the fetus and newborn. Pathophysiology: if the fetal RH positive red blood cells enter the maternal circulation, keep imagining as I read it out. There are maternal fetal RBCs which are RH positive entering the maternal circulation. The RH negative mother's immune system doesn't have the RH antigen, so there are antibodies against the so this thing, what is it, the fetal antigens, RH antigen act as a foreign antibody antigen into the in the maternal circulation. So then the mom produces antibodies. These antibodies cross the placenta in subsequent pregnancies and destroy the fetal RH positive RBCs, leading to hemolysis. So the issue comes up during the next set of pregnancies. So this is a very simple concept, you can understand just with a small Google search or taking a look at diagrams in your textbooks. Yeah, coming to the risk factors for sensitization. So this is where our clinical side comes in. Risk factors: obstetric events and non-obstetric events. What are the obstetric events? Previous RH positive pregnancies, miscarriage, abortion and ectopic pregnancy, wherein so whenever there is the chance of the maternal the fetal RH positive RBCs entering the maternal circulation, there we can find this particular issue. So considering that, there could be antepartum hemorrhage, amniocentesis, chorionic villi sampling, and other invasive procedures, external cephalic version, delivery of an RH positive baby. So all of these things, increased tendency of the contact. Non-obstetric events: blood transfusion with RH positive blood. So not just the fetal RBC, some other person might give some blood which has the antigens, and that might induce antibody formation. Trauma to the abdomen during pregnancy, so even that can lead to the contact of the RH positive blood. Clinical features: so mom is usually asymptomatic, but complications arise in the fetus and newborns due to hemolysis. So that is the key word here, hemolysis repeated everywhere. So we have mild cases, severe cases. Mild cases: neonatal jaundice within 24 hours of birth, and severe cases: hydrops fetalis. There could be generalized edema, ascites, pleural effusion, intrauterine fetal death, severe anemia in fetus or newborn, and kernicterus. So hydrops fetalis, intrauterine fetal death, severe anemia in fetus or newborn, and kernicterus, which is bilirubin induced brain damage. Why bilirubin? Because there is a lot of hemolysis going on, and the bilirubin just can go to the brain, and since it is very attracted to the brain tissue, it can cause damage there. Yeah, coming to the investigations: maternal testing, paternal testing, fetal monitoring, and postnatal testing. Coming to maternal testing: blood group and RH typing to confirm RH negative status. So that is number one, confirming what the blood group is. Indirect Coombs test detects anti-D antibodies in maternal serum. So already we have determined the blood group, and now we need to know, is there any chance of that happening, the issue of hemolysis. For that we do this particular test, detecting anti-D antibodies, anti-RH antibodies in the maternal serum, performed at the first prenatal visit and at 28 weeks of gestation. At 28 weeks of gestation and first prenatal visit, 2 places. Next coming to paternal testing, RH typing of father to determine the risk of fetal RH positivity. So that is another thing. Fetal monitoring, there is ultrasound, MCA Doppler. So we have seen this already previously. Let's go through this. To assess for signs of fetal anemia or hydrops fetalis. Let's check if the mic is on. Yes, it is. To assess the signs of fetal anemia or hydrops fetalis. So that is one thing, and let's check this, why this is the case. To assess the signs of fetal anemia, hydrops fetalis. Why in RH negative mom. How does that actually happen? Why ultrasound? Yes. So it can detect that, we know it already. Okay. So these are the things, signs of fetal hydrops fetalis on ultrasound: ascites, pleural effusion, pericardial effusion, skin edema. So basically everything looks big. No need of looking anything else extra. Coming to MCA Doppler to detect fetal anemia, same thing which is mentioned over here. MCA R3, peak systolic velocity. It's the same thing. Due to anemia, the fetus compensates with increasing cardiac output, causing faster blood flow. So this particular thing, I think we have studied this previously too. I think in what was it? Most likely pediatrics, the newborn section. Not 100% sure. No, it was not pediatrics. Somewhere we have learned this. MCA Doppler. Which one was it? Something related to, forget about it. No need to worry. Coming to postnatal testing, direct Coombs test. So earlier it was RH indirect Coombs test. Here it is direct Coombs test on the newborns to detect antibody coated RBCs. So baby is already born, and now we need to know whether the RBCs are already being attacked. So this one detects the antibodies coated on the RBCs. So detection of the antibody is direct, and detection of the antigen, detection of anti-D antibodies in the maternal serum is indirect, and detection of antibody coated RBCs in the newborn is direct. Newborn blood group and RH typing. So those are the things: maternal testing, paternal testing, fetal monitoring where ultrasound and MCA Doppler is done, postnatal testing and direct Coombs test, newborn blood group and RH typing. So those are the things. Coming to the management, prevention of sensitization, management of sensitized pregnancy and postnatal care. So sensitization, that is what it is. Blood comes in contact and it sensitizes the immune system. So how do you prevent it? Anti-D immunoglobulin or ROD, immune globulin given to all unsensitized RH negative women at 28 weeks of gestation. So testing is done at 28 weeks too. So all unsensitized RH negative women are given that additional dose within 72 hours of delivery. 72 hours, how much does it come up to? 72 hours divided by 24, it is 3 days if the baby is RH positive. So within 3 days, anti-D immunoglobulin. Also administered after sensitizing event like miscarriage, amniocentesis or any of these. What are they? Let's look at them again. All of these. Yes, anything that can cause sensitization. Management of sensitized pregnancy, already sensitized, what to do now? Close monitoring, fetal surveillance, intrauterine transfusion, early delivery. Close monitoring, fetal surveillance, intrauterine transfusion and early delivery. First one, serial indirect Coombs test to monitor antibody levels. Fetal surveillance, ultrasound and MCA Doppler for fetal anemia. Intrauterine transfusion for severe fetal anemia again. So, and early delivery considered if fetal condition deteriorates usually after 34 weeks. So, early delivery if condition goes bad. Yeah, so yeah, those were the things about sensitized pregnancy. Next, coming to postnatal care. Now the baby is born. So, how do you manage? Phototherapy and exchange transfusion. Phototherapy for neonatal jaundice and exchange transfusion in severe cases of hemolytic disease. Phototherapy for neonatal jaundice and exchange transfusion in case of hemolytic disease. So, those are the things for postnatal. Coming to complications. So, what could go wrong? Everything. Yeah. So, for the fetus and newborn, hemolytic disease of the fetus and newborn, hydrops fetalis, intrauterine fetal death, neonatal jaundice and kernicterus. For the mother, increased risk of sensitization in subsequent pregnancies if not managed appropriately. So, these are the things. So, sensitization on mom's side, because asymptomatic mom, that is usually senior, and on the fetal side the worst case scenario is intrauterine fetal death, and if it is alive, kernicterus could also be seen. Prevention: routine antenatal care, prompt management of sensitizing events, education and counseling. So, these are the three things. So, first one, routine antenatal care, blood group and RH typing at the first prenatal visit, administration of anti-D immunoglobulin as per the guidelines. So blood grouping, anti-D immunoglobulins, main things. Prompt management of sensitizing events. So, already sensitization has happened. So, what do we do? Again, anti-D immunoglobulin plays a very important role, especially within 3 days of any potential fetal maternal hemorrhage. Within 3 days. So, even over here within 72 hours of delivery, and over here it is any kind of fetal maternal hemorrhage. Education and counseling. Inform RH negative women about the importance of regular follow-up and adherence to prophylactic measures. Yes. So, education and counseling is the final thing. Prognosis: with appropriate prophylaxis and monitoring, most RH negative pregnancies can be managed successfully, and the risk of hemolytic disease in the fetus or newborn is significantly reduced. So, with that we have finished all the aspects of, most of the aspects of RH isoimmunization. This can come as a 5 marker, so better to understand it properly. Yeah, so now we'll move on to the next one, VBAC. Yeah, VBAC. So, looking at this, what else comes to your mind? Just close your eyes. I'll tell you what comes to my mind. AMTSL, because they are two weird names, weird words which you need to remember, and they can ask like this too. This one, AMTSL, and there's another one, TOLAC. Yes, all these things are foreign words, very difficult to wrap your head around in case you are looking at them for the first time. You can't even make up an answer just by looking at the preterm labor. Yeah, you can write something. Yeah, you can write something from previous few years. Physiology, pathology, anatomy. I'm not sure about that. Maybe yes, you can write something from histo. But VBAC you can't write anything. Even TOLAC you can't write anything. AMTSL you can't. Yeah, so VBAC. Let's begin. Overview. VBAC, vaginal birth after cesarean. So, now it makes a little more sense. Vaginal birth after cesarean refers to a trial of labor after cesarean. So, it is a TOLAC, trial of labor after cesarean in an attempt to achieve vaginal delivery. So, the goal is to achieve vaginal delivery. So, V stands for vaginal delivery. Vaginal birth, VBAC, after cesarean section. It is successful in 60 to 80% of the cases and has several benefits, provided the case is carefully selected and managed. So, now TOLAC, trial of labor after cesarean. So, trial meaning you try it. So, what are the selection terms, criteria? 1 or 2 previous lower segment transverse cesarean sections. So, 1 or 2 previous lower segment transverse cesarean section, that is number 1. Non-recurring indication for previous cesarean. So, non-recurring indication for previous cesarean. So, previous cesarean happened, but the indication is non-recurring, meaning it doesn't have to be repeated again. You understand? Last time the doctor said we'll do cesarean, but only for this pregnancy. We don't know about the next one. Mostly no, but we don't know. If that is the case, then we can start with TOLAC. Pelvis assessed to be adequate for fetal passage. We know that baby can pass through the pelvis very easily. There are no obstruction or anything of that sort. Continuous labor monitoring is possible. Yes, labor monitoring is possible. Availability of anesthesia, blood transfusion and surgical intervention within 30 minutes if needed. Availability of anesthesia, blood transfusion and surgical intervention within 30 minutes if needed. Informed consent of the woman. So that is the last one. Yeah, so we are done with the selection criteria. Now what are the contraindications of TOLAC? Could there be any contraindications? Yes, there are. 1, 2, 3, 4, 5, 6. There are 6 contraindications. Number 1, previous classical or inverted T-shaped uterine incision. Let's look at an image which shows this, so that we can have an idea or at least get some logic as to why that is the case. So inverse T, this is the one. Inverse T classical. Should we go into the reason why this is the case? Let's finish up all of these, then decide in case we have understood everything or nothing. Yeah, more than 2 prior lower segment cesarean sections, LSCS. So this one makes sense. You don't want a lot of uterine contractions to occur after so many C-sections. Why? Because uterus can rupture. That is one thing. Suspected cephalopelvic disproportion or contracted pelvis. So in that particular case, there is no good passage. Passage is not good. In that particular case, yes, we can try out. We can't try out TOLAC. Yeah, we can't do TOLAC. Presence of obstetric complications, preeclampsia, pelvic placenta previa, malpresentation. So in these particular cases, it is better to go with C-section. And limited resources for emergency cesarean, because you are trying it out, right? So you are trying it out, and there could be a possibility of emergency C-section. We don't want that. We want everything planned. So if we want everything to be planned, emergency C-section is something which needs to be kept in mind. If this can't be done, better to avoid this. Did my last sentence make any sense? In my head it made sense, but as a viewer I am not sure. History of prior uterine rupture. So again referring to this particular one. Anyways, let's copy this. This is the only thing that we didn't understand. I didn't understand. So the reason I am saying we is to reduce the responsibility. Yeah, please why a contraindication for TOLAC. Yes. Why? Because extends into the upper portion of the uterus. The upper portion is thinner and weaker compared to lower segment, making it more prone to rupture under labor stress. Uterine rupture can lead to hemorrhage, fetal distress and even maternal or fetal death. So again uterine rupture. So these are the things. So we have seen the selection criteria, contraindications. Now coming to benefits of VBAC. Vaginal birth after cesarean. Decreased maternal morbidity, infections, anesthesia, complications. So it is basically cesarean is operative procedure, right? So because of that, it is one of the reasons in obstetrics why it is surgical in nature. So this is one of the surgical procedures in obstetrics. So surgical procedures can have their adverse effects. So that is one thing. Reduced hospital stay and healthcare cost, even that contributes. So that less blood loss and decreased need for transfusion. So another thing. Lower risk of abnormal placentation in subsequent pregnancies. So why? Because one of the risk factors of abnormal placentation is previous C-sections. So we avoid these things with VBAC, vaginal delivery, vaginal birth. Yeah, risk of elective repeat cesarean section. So risk of elective repeat cesarean section. So cesarean section has happened previously. Now instead of doing VBAC, we are doing cesarean. Yeah. So increased maternal morbidity and infection risk, high incidence of hemorrhage and need for transfusion, risk of placenta previa and accurate and future pregnancies, higher neonatal risk such as respiratory distress syndrome. So basically just opposite of this thing, just writing opposite of this for ARCS. Complications of unsuccessful TOLAC. So TOLAC, VBAC. Yeah, so actually these are very funny names. Yeah, coming back to TOLAC. Uterine wound dehiscence or rupture, that is number 1, because it like very much of too many contractions that are happening. Increased maternal morbidity and infections or hysterectomy. So these are some other things. Complications: maternal morbidity, infections, hysterectomy. Why specific infections? Infections was there for the unsuccessful. Okay, fine, unsuccessful. Maybe because we are jumping onto this. And perinatal complications include baby, lower Apgar scores, NICU admission, stillbirth, and neonatal death. Let's try to understand. TOLAC. What was the question about? The unsuccessful TOLAC. Why is it? We know why it is tried in the first place. No. Why can it become unsuccessful? Why can it be not? Why can it be unsuccessful? Yes, unsuccessful. Yes. So why a trial of labor can be unsuccessful? It results if it is a failed VBAC. Okay, leading to repeat C-section. Okay, so the goal is, if it reaches this particular region, emergency repeat C-section, it is a failure of TOLAC. It makes sense. Now they are given a few causes: failure, descent. Okay, some issues that can probably make you do. Okay, so and why infections, right? So here they have mentioned rest of the things make sense. Why these? Yeah. Why? In that case, yes. Why that is the case? Because here it's not mentioned. Yeah, increased maternal morbidity, prolonged labor, exhaustion, blood loss. Yeah, increase. Okay, because of this prolonged labor, urgency of surgery, complications due to less preparation time, adhesions from prior C-section. Okay, risk of infection, chorioamnitis, endometritis, more common, prolonged labor, prolonged operative time. So it is basically, it is unplanned. Hysterectomy because of rupture. So we are going double steps. One was rupture itself, because you are contracting the uterus so much. Another thing is post rupture you are doing hysterectomy, so that is another one. So that also they have mentioned it here. Increased blood loss, need for transfusion. Yes. Okay, fine. Finally, coming to the management of labor and delivery for TOLAC. Labor induction and monitoring, intrapartum care and delivery consideration. So number 1, labor induction and monitoring. Spontaneous onset of labor is preferred. Okay, so and induction with prostaglandins increase the uterine rupture risk and should be avoided. Why? Because previously it has been C-section, so we don't want rupture to occur. So spontaneous onset of labor is preferred. We don't want anything extra. Mechanical methods like Foley's catheterization are safer. So okay, fine, this one is safe. Continuous electrical fetal monitoring is recommended to detect fetal distress early. Next, coming to so electrical fetal monitoring was the last point. Next, coming to intrapartum care. IV fluids with Ringer's solution should be started. That is number 1. IV fluids with Ringer's solution. Blood sample to be sent for hemoglobin, blood grouping and cross matching, because blood transfusion could be possible because of emergency C-section. Epidural analgesia is not contraindicated but should be carefully monitored. Epidural anesthesia is not contraindicated. Why is this the case? Epidural anesthesia. Let's take a look. I know this is going for too long, but this is a topic I didn't pay much attention even during my regular college time. Like that was the case with a good chunk of obstetrics in general, because it was not my favorite, the most favorite one. But now it is my favorite because I am spending hours and hours on it. Why in TOLAC? But even then, conceptually it is fine. If you can make up answers just by looking at the question, meaning if it is, then it is lot more conceptual. If you have to memorize a lot of things, that means it is not conceptual. Yeah, why should it be monitored? Uterine rupture may present as sudden severe pain. Okay, so it is basically something like this, which was the condition wherein there was some kind of neurological disorder where the pain is dampened, and because of that you can't actually make, yeah, it was diabetic foot, right? So the base of the foot, it had some ulcer, and because of that repeatedly, but there is no pain. Why? Because the nerve endings are damaged, and because of that slowly you have reached weird extreme severe case. So similarly over here, uterine rupture presents at severe pain, but if you have analgesia, the pain is not there. That is another one. Fetal station can be overlooked. Uterine rupture can the fetus to move out of the uterus. Loss of station with epidural, they may not feel the change. All right. Hypotension, fetal distress can still occur. Should I copy all of these things? That's a very good idea in my opinion. So I'll just, sorry about making you docs new. Yeah, so let's make this OBG 4 hours first session. So this is going to be a 4-hour session. How many? Okay, so almost 1/8 is done. So this is number 1. This is RH. Yeah, RH negative. It's more RH. That is number 1. Next, coming to C section. So this is C section. So let's copy this, and finally this one too. Yes, this one. Yeah, this one also 2 lakh, and finally this one 2 lakh. Yeah, still in 2 lakh, because 2 lakh we need to make sure we are comfortable with. Let me take a smaller. Yeah, we need to make sure that we need to spend, the more time we spend with, I have realized this in final year, that the more time you spend with a particular subject, the more comfortable you become with the subject, like in real life with real people. Yeah, oxytocin for labor augmentation should be used judiciously, because yeah, again makes sense. Delivery consideration, prophylactic forceps or ventouse can be used to shorten the second stage. All right. So this one is doable, forceps or ventouse. We have that topic separately. Routine uterine scar exploration is debated. It is done selectively if excessive bleeding or maternal hypotension occurs. Caesarean section should be performed promptly if signs of rupture like severe variable deceleration or prolonged bradycardia occur. So caesarean section like as soon as possible if signs of rupture, like signs are severe variable deceleration, prolonged bradycardia. So with this we have come to the end of this particular topic. We back. So probably it was a 5 marker. I am not sure 100%. It's a 5 or 3. Mostly 5. Like maybe it's both. Can't actually tell. And next, coming to contracted pelvis. So this one, first topic in this particular thing. 1 minute. We have cephalopelvic disproportion, CPD, very important topic both for theory as well as the practicals. CPD is a condition where fetal head is too large to pass through the maternal pelvis due to disproportion between fetal size and maternal pelvic dimensions. So the passage is not fine. That is what it is. It is a condition where fetal head is too large to pass through the maternal pelvis due to disproportion between the fetal size and maternal pelvic dimensions. Definition: it results from either large fetal head or small maternal pelvis or combination of both. CPD may cause labor dystocia, that is abnormal labor, prolonged labor or obstructed labor. Yeah, so these are the things, general overview, definition along with why possibly it can occur. Coming to the assessment. So let's take a look overall what we are going to learn. Assessment of CPD, degree of CPD, timing of assessment and management. So it's a very short topic even in Datta. So can't really do much. It's a 5 marker. We need to put this as a 5 marker. Maybe you can add up something extra from other answers too. Yeah, so assessment of CPD, clinical assessment. So number 1, abdominal method, abdominal vaginal method, Muller-Munro-Kerr method. Fine. First one, the patient is placed in dorsal position with slightly flexed thighs. The fetal head is palpated through the abdomen to assess the engagement and overlap of the parietal bone at pubic symphysis. You need to see the image, otherwise it doesn't make sense. Abdominal method of, it can detect it, maybe it can hear the voice. Okay, dorsal position with thighs slightly flexed. The head is grasped with the left hand. The left hand is used to grasp the head, and then 2 fingers, index or middle finger of the right hand, are placed above the pubic symphysis, keeping the inner surface of the fingers in line with the anterior surface of the pubic symphysis. Inner line of the fingers, this one. So this one, that is what it is, this one. To note the degree of overlapping, if any, and the fetal head is pushed downwards and backwards, then it is a problem, most likely. Should I open this? No, it's somebody else's. You're not touching that. So basically that is the method all about. The fetal head is palpated through the abdomen to assess engagement and overlap of the parietal bone at the pubic symphysis. At the pubic symphysis, if the overlapping of these skull bones happen, that means there is problem with the passage. It is not enough for the fetal head. So that is what we are checking with the abdominal method. So dorsal position, thighs flexed, one hand on pubic symphysis, another hand palpating the fetal head, and as the fetal head passes near the pubic symphysis, if there is overlapping of parietal bones, that means there is CPD. That is one of the methods. Number 2, abdomino-vaginal method, which is also known as Muller-Munro-Kerr method. Bimanual technique where vaginal fingers assess descent at the level of ischial spines and thumb is placed over pubic symphysis to detect overlap. Again, we need to take a look at the image to better understand what is happening. Yes, so over here you can see the one of the hands, the fingers are inside the vagina and the other is palpating the fetal head, and with this we can bimanual technique where vaginal fingers assess the descent at the level of ischial spines and the thumb is placed over the pubic symphysis to detect overlap. So overlap of the parietal bones is what we are looking at again in the Muller-Munro-Kerr method. So this one is somewhat weird name, but it's fine. We had something else, some doctrine. Even that one is somewhat similar, it has similar tone. So Muller-Munro-Kerr method, which is abdomino-vaginal method. So we are done with the clinical assessment. Coming to imaging pelvimetry, there is X-ray pelvimetry, cephalometry. Number 1, lateral X-ray with the patient standing helps assess CPD at various planes, inlet, mid, pelvic and outlet. Lateral X-ray with patient standing helps assess CPD at various planes, inlet, mid, pelvic and outlet. And there is cephalometry, ultrasound and MRI. Ultrasound measures the fetal biparietal diameter and compares it to the maternal pelvic dimensions. So ultrasound measures fetal biparietal diameter and compares it to the maternal pelvic dimensions. MRI provides a detailed assessment of fetal head and pelvic anatomy. Ultrasound and MRI both for cephalometry. So we are done with the assessment of CPD. Coming to the degree of CPD. CPD can be categorized based on the clinical and imaging findings. Number 1, severe CPD, obstetric conjugate less than 7.5 centimeter. You can say it is 75 mm. Borderline CPD, obstetric conjugate between 9.5 and 10 cm with reduced transverse diameter of the inlet. Let's take a look at the conjugate. So, diagonal conjugate obstetric. Yeah, so obstetric, this one is what we are looking at. This is what promontory into the midpoint of symphysis, not symphysis. So, it's the symphysis. Yeah, that is what we are looking at. Yeah, see, it's the symphysis. So, promontory to the symphysis. If it is less than 7.5, it is severe. If it is between 9.5 to 10, it is borderline with reduced transverse diameter of the inlet. Coming to timing of assessment and management, there is during pregnancy, during labor, and mode of delivery. During pregnancy, CPD assessment is crucial in women with a history of difficult vaginal delivery and fetal macrosmia or suspected pelvic abnormalities. So, that is number 1. Imaging studies can be performed in late pregnancy to evaluate fetal head and pelvic capacity. So, yeah, so macrosmia is what we are thinking about, and and also difficulty history, previous pregnancies with difficulty vaginal delivery and suspected pelvic abnormalities. During labor, so this is during pregnancy. Now coming to during labor, trial of labor may be attempted under strict supervision if CPD is borderline. What is the definition? 9.5 and 10, between that. Continuous electronic fetal monitoring is essential to detect fetal distress. Continuous electronic fetal monitoring. Failure of head engagement, prolonged labor, or signs of maternal or fetal distress indicate the need for cesarean section. Failure of head engagement, prolonged labor, and signs of maternal or fetal distress indicate need for cesarean section. So, this is another thing. So, again, during labor, what do we do? Trial of labor under supervision for borderline. EFM, electronic fetal monitoring, and then we check for engagement, prolonged labor, or signs of distress to move to cesarean section as soon as possible. Coming to mode of delivery, that is we are looking at induction of labor, elective cesarean, and trial of labor. Number 1, induction considered only in cases of mild to moderate CPD. Mild to moderate CPD. Elective cesarean recommended in cases of severe CPD, major pelvic contraction and or maternal or fetal complications. Recommended in cases of severe CPD, major pelvic contraction or maternal fetal complications. So, that is elective. Trial of labor conducted under close monitoring in mild cases to avoid unnecessary C-section. We have 12 minutes more. It is quite, it feels like a really long time. Yeah. Anyways, we are done this with this CPD. We have understood quite a lot of things. So, first we looked at the definition, then we looked at the assessment. In clinical assessment, we looked at 2 methods. In imaging, we learnt about X-ray pelvimetry, where we look at 3 different planes, and cephalometry we looked at ultrasound, MRI, and degrees of CPD we learnt about based on obstetric conjugate. We learnt about 2 different ones, severe and borderline, and based on the timing timing of assessment and management, there is during pregnancy, during labor, and mode of delivery. And specifically we looked at what are things we look at specifically during the labor, and also induction of labor aspect, elective C-section, and trial of labor, and all of those things. And with this we come to the end of the topic CPD. Let me close this. Yes. Now coming to the next one, trial of labor. Yeah. Trial of labor is the conduction of spontaneous labor in a minor to moderate degree of cephalopelvic disproportion in an institution under supervision with watchful expectancy, hoping for vaginal delivery. So, trial of labor is the conduction of spontaneous labor. So, we are trying for spontaneous labor in a mild to moderate degree of CPD. So, it is like a continuation of the previous answer. So, mild to moderate CPD is happening. We want spontaneous labor in an institution under supervision with watchful expectancy, hoping for vaginal delivery. It aims to avoid unnecessary cesarean sections while ensuring maternal and fetal safety. unnecessary cesarean sections. It aims to avoid unnecessary cesarean sections while ensuring maternal and fetal safety. Sorry for the pause. Yeah, if labor fails to, I was just processing the previous statement. That's what I was looking at the time, and it's not. Yeah, I need a break. Anyways, we'll continue and we'll stop at exactly within next 10 minutes, 30 seconds. Yeah, it aims to avoid unnecessary cesarean sections while ensuring maternal and fetal safety. Yeah, so no cesarean. We don't want cesarean in trial of labor. If labor fails to progress or complications arise, operative intervention like C-section or instrumental delivery is performed. So we avoid it at all costs, but in case complications arise or it fails to progress, we do the intervention. Coming to aims of trial labor, yeah, to avoid unnecessary cesarean section. That is number one. We have seen it repeatedly here. To ensure healthy vaginal delivery, that was another one. Close this one. To test pelvic adequacy and integrity of a previous cesarean scar. To test pelvic adequacy and integrity of previous cesarean scar. So previously, if there was a scar, we are checking for pelvic adequacy and how good is it. Yeah, that is what. And coming to contraindications. Associated mid pelvic or outlet contraction. So that we studied in this one, right? X-ray pelvimetry for cephalometry. Right, X-ray pelvimetry. Yeah. So in those, if these two planes, pelvimetric, mid pelvic or outlet, if there is contraction, yeah, then it is a contraindication. Obstetric complications like preeclampsia, post maturity, malpresentation, post cesarean pregnancy. Preeclampsia, post maturity, malpresentation, post cesarean pregnancy. Medical disorders such as heart diseases, diabetes, tuberculosis. Heart disease, diabetes and tuberculosis. In those cases, we are not doing the trial of labor. Lack of facilities for emergency cesarean section, because anyways it might turn into that emergency cesarean. It is not toe lack per se, it is trial of labor. Which was this? Wait a second. There is trial of labor after cell. So just TOL, not toe lack. Toe lack is different from trial of labor. Yeah. So conduction of trial of labor. Onset of labor, monitoring and progress assessment, and augmentation of labor. So onset of labor, preferably spontaneous, because that is the definition, spontaneous labor. Induction may be done if labor fails to start. So here, okay, fine, we can start with the labor, but in toe lack that was not the case. Why? Previously it was cesarean section, and if we start with some kind of induction procedures, it can rupture, but here that is not specifically the thing. Toe lack, AC is missing. And monitoring and progress assessment, oral feeding is restricted and hydration is maintained with IV fluids. Progress is assessed with partograph, just like normal labor. Descent of pelvic head, sorry, not pelvic head, the funniest thing, fetal head, not pelvic head. Descent of fetal head and cervical dilatation is what we are looking at through partograph, what we are assessing with partograph. Progress is monitored. Continuous fetal monitoring using CTG EFM, CTG cardiotopography and electric fetal monitoring. Membrane rupture followed by vaginal examination to assess color of liquor, position and molding of fetal head and cervical condition. So membrane rupture followed by vaginal examination to assess color of liquor, position and molding of fetal head and cervical condition. Augmentation of labor. Amniotomy or oxytocin infusion if contractions are inadequate. So oxytocin or amniotomy. If this one, that was not the case previously again. And then augmentation is contraindicated unless the cervix is 3 centimeters dilated. Alright, this one makes sense. I am looking at this because I think I just read through this. I didn't try to, yeah, membrane rupture followed by vaginal examination. So to assess color of like position molding of fetal head and cervical condition. Alright, something. Wait, we can't make it something like something. We can't say that we are medical students. Abdominal rupture followed by vaginal examination. Why is this mentioned in trial of labor? Yes, we need to know this. Why assess membrane rupture in not Tolak? Anyways, it's somewhat similar, but this is specifically cesarean, but there it is CPD related. Clear normal. So key assessment of membrane. So it's a critical event that requires immediate assessment to detect complications early, including signs of uterine rupture, fetal distress, or labor progress abnormalities. So key assessments: color of position and molding of fetal head. So that is another thing. Cervical condition to assess the readiness for delivery. Why is this extra? So yeah, trial of labor, not Tolak, but just CPD related trial of labor. During these 4-hour sessions and all that, it feels really nice to actually go through the topic in depth. If it was a 10-minute or 15-minute, it felt like I need to restrict myself to this specific time period, but here it is fine. If it takes longer, it is fine. Anyways, we have a lot of time. Why assess in trial of labor rupture? Yeah, this one. Detect fetal distress. Yes, it was the same thing previously. Fetal distress and all that. Normal meconium, fetal distress, bloodstream may indicate placenta abruption, foul smelling suggesting chorioamnitis. Position and molding of fetal head. Occipito anterior, best for vaginal delivery. Occipito posterior on trauma, higher chance of failed TOL. Mild molding, normal adaptation. Severe molding, arrested labor suggests CPD. Cervical condition, labor readiness and progression. Dilatation, slow or no progress despite some contraction. Effacement, thinning of cervix should progress with labor. If not, CPD may be preventing descent. Yeah, so basically these are the things. Anyways, if you have to go through this, you can just use this. So what is the thing? CPD, TOL. I'll just mention it as TOL. In case you want to go through, you can go through this. But personally, it makes sense for me right now. Why? These things are specifically measured in this. Yeah. Next, coming to augmentation, amniotomy. This one we are done. Favorable features of successful trial: normal pelvic shape, favorable fetal position, effective uterine contraction, intact fetal membranes, and maternal emotional support. So all of these things suggest good successful trial labor. Unfavorable features suggesting failure: abnormal uterine contraction, cervical dilatation less than 1 cm per hour in active phase, fetal head descent less than 1 cm per hour in active phase, arrest of cervical dilatation despite oxytocin use, early rupture of membranes, excessive molding of fetal head, and fetal distress. So these are the things. Coming to termination of trial labor, spontaneous vaginal delivery, that is number 1. Next, coming to assisted vaginal delivery, number 2, forceps or ventouse if needed. Spontaneous, assisted vaginal delivery, and next one is cesarean. That happens in 40% of the case. So this is the probability of what can happen terminating the followed by this. Number 1, spontaneous vaginal. Next one, assisted vaginal, forceps or ventouse. Cesarean section indicated if labor fails to progress, fetal distress occurs, or maternal complications arise. So basically only 3 possible paths. One is specific, natural way, it is spontaneous labor. Like if it is not spontaneous, induction can happen. We can go about inducing labor. That is it here? That was the previous one, I guess. No, here itself. So induction of labor. So that is number 2. And if that is not there, assisted labor techniques. So that is meaning possible paths. Assisted vaginal delivery, the forceps or ventouse. And final, there is cesarean section, which is another outcome. Outcomes of successful trial labor: vaginal birth with good maternal and fetal outcome. So, that wasn't that the goal. Yeah, conduction of spontaneous labor in minor to moderate degree of cephalopelvic disproportion. So, goal was to avoid unnecessary C-section, deliver healthy vaginal, ensure healthy vaginal delivery, and to test the pelvic adequacy and all that. So, pelvic adequacy and all that we have reached, the features and all that we got to know, and successful this thing, vaginal birth with good maternal and fetal outcome, avoidance of unnecessary C-section. Yes, that is a good outcome for this particular case. Avoidance, advantages: reduces unnecessary cesarean deliveries, lowers risk of preterm labor due to induction. Okay, that is another one. Ensures good reproductive outcomes for future pregnancies, because we are trying our best to avoid cesarean. Yeah, and preterm is also avoided. Disadvantage: it does not always confirm disproportion if cesarean is required. So that was one of the goals, right, to detect whether disproportion is there or not. Increased, we'll close this, it feels really good, but I'm finally getting the momentum. Increased risk of fetal morbidity, mortality, increased maternal morbidity due to prolonged labor, and psychological stress if the trial fails and ends in emergency surgery. So that is the final one. Conclusion, should we go through this? No. Anyways, we'll go through this since it's already almost done. Trial of labor should be carefully planned and conducted in well equipped facilities under strict supervision. While it can help reduce unnecessary C-sections, timely intervention is crucial to prevent maternal and fetal complications. With this, we end the topic trial of labor, and then we are going to go to the next ones after the break. Turn this off. Welcome back. Let's begin. Before that, I forgot to drink water. Yeah, let's begin. Yeah, so we were in the, let's begin with abnormal uterine action. Number 1, Bandel's ring. Before going there, let's look at an image. So since this looks like an image based, it is an image based. It's an image based thing. So here you can see there is a thickened upper uterine segment and thin ballooning stretched lower uterine segment, and there is this ring that is being formed, and you can imagine what could possibly go wrong. Fetal distress, fetal asphyxia, those are the two major ones just by looking at it. So definition. Bandel's ring is also known as pathological retraction ring. Even this can come as a question. Is a circular groove encircling the uterus that forms between the actively contracting upper uterine segment and distended lower uterine segment. It is the sign of obstructed labor and indicates impending uterine rupture leading to severe maternal and fetal complications. So again, it is a circular groove encircling, I am not highlighting this, encircling the uterus that forms between the actively contracting upper uterine segment and the distended lower uterine segment, sign of obstructed labor and indicates impending uterine rupture. Coming to pathophysiology. During prolonged obstructed labor, uterine contractions become increasingly strong with inadequate relaxation. So it's like it's like a CPU that tries its best. You are overclocking the CPU. That analogy makes sense. Or else something like you are trying to rev up the engine, but the tires aren't functioning. No, not the tires. The wheels aren't working properly. Something like that, wherein you are trying your best, but and there is infrequent relaxation. That is what is happening. The analogy doesn't add up, but it doesn't make a lot of sense, but this one makes sense, whatever is written here. This leads to excessive elongation and thinning of lower uterine segment. The pathological retraction ring gradually rises towards the umbilicus, signaling extreme uterine retraction and impending rupture. The pathological retraction ring gradually rises towards the umbilicus, signaling extreme uterine retraction and impending rupture. So it comes up and up and up towards the umbilicus and eventually ruptures. That is what the issue is. Clinical features: maternal symptoms, abdominal examination and vaginal examination. So symptoms, and these are signs: severe continuous pain, discomfort, restlessness and signs of maternal exhaustion, features of dehydration and ketoacidosis. Severe continuous pain and discomfort, restlessness, signs of maternal exhaustion and features of dehydration and ketoacidosis. Three things. First one makes sense, this one makes sense because it's too much of contraction. Features of dehydration, ketoacidosis. We need to know why this is the case in this thing. So let's why in Bandel's ring. Excessive fluid loss leading to reduction in fluid volume and imbalance. And ketoacidosis, no. But it makes sense though. No, not that. Bandel's ring, pathological retraction ring, Yeah. Dehydration, excessive fluid loss. Yeah, all right. Not hopefully that is not again. Yeah, this one makes sense. Yeah, this one. Yeah. Serious dangerous sign. All right. However, dehydration can contribute to its formation. Okay, this is causing its formation. How dehydration and ketoacidosis contribute? Dehydration leads to reduced uterine perfusion, and ketoacidosis leads to metabolic disturbances. All right, these two things: dehydration leading to reduced uterine perfusion, ketoacidosis leading to metabolic disturbances, and both of these things can cause uterine contraction, lot of it, and uterine exhaustion, leading to Bandel's ring. which is a sign of impending uterine rupture. So, this has been repeated multiple times, when there, over here, it is very important. Alright, so then coming to signs. So, there is abdominal examination sign and vaginal examination. So, upper uterine segment is hard and tender, this one makes sense. Lower uterine segment excessively stretched and tender, excessively stretched. Pathological retraction ring visible as a groove between the upper and lower segments. Vaginal examination, lower segment is excessively thinned and tightly pressed against the presenting part. Tightly pressed against the presenting part, this one. This is what they are talking about. Yeah, and features of obstructed labor including failure of descent of the fetal head. Okay. Have they mentioned about the complications? No, it's not required problem, but that is possible, asphyxia and all that. Constriction. So, here they have here there is a difference between constriction ring and retraction ring. Let us look at the difference, because even this can come as a question. First, on constriction ring, localized incoordinate contraction. This one is end stage of tonic uterine contraction. This one is localized in coordinate. Maybe this is less severe. This suggests uterine irritability. This one is obstructed labor. This can occur anywhere, but this is specifically between the junction of upper and lower uterine segment. Effect on the uterus: upper segment contracts and relaxes, lower segment remains soft. In this particular case, upper segment tonically contracted, lower thinned and distended. Alright. Maternal condition generally unaffected. In this particular case, features of exhaustion and sepsis. Abdominal examination, normal uterine tone. Here uterus is tense, this one palpable as a groove. Under this case, ring is not felt, head is often engaged, ring presses tightly and obstructed labor signs present. End result usually does not cause rupture, this one causes. Treatment principle: relax uterus, deliver the baby vaginally or by C-section, immediately C-section after ruling out rupture. So, these were the things. Let's just check it out here. What is it? It is an excessive contraction of small segment of the uterus around a specific part of the fetus, usually during labor. We do not want to know the difference because we have already seen the difference here, but we need to know function and pathological. So, this one was the pathological one. Functional is temporary localized contraction of uterine muscle around the fetus, commonly seen around the fetal head, neck, breech, can usually be relieved with tocolytic drugs that relax the uterus. Hypotonic uterine contraction, malpresentation, use of excessive oxytocin, irritation. Clinical features: sudden arrest of labor, localized indentation on the uterus, persistent pain between contraction and fetal distress. So, those are the things. Yeah. So, now coming to the management. Finally, prevention and treatment. Prevention: close monitoring of labor progression with partograph. Early identification of disproportion or malpresentation. Timely cesarean delivery in high risk cases. So, close monitoring of labor progression with partograph, early identification of disproportionate or malpresentation, and timely cesarean section in high risk cases, because all we want is uterus to not rupture. Yeah. Coming to the treatment: immediate exclusion of uterine rupture, supportive management and definitive management. Number 1, clinical assessment and imaging to confirm intact uterus. Number 2, correction of dehydration and ketoacidosis, adequate analgesia, parenteral antibiotics to prevent sepsis. Number 1, correction of dehydration and ketoacidosis, IV ringer lactate, adequate analgesia, epidural if possible, and parenteral antibiotics to prevent sepsis, because that is a possible scenario here. Definitive management: cesarean delivery is the treatment of choice in most cases. If uterine rupture is diagnosed, laparotomy with repair or hysterectomy may be necessary. Finally, prognosis: early detection and prompt cesarean delivery significantly reduces maternal and fetal complications. Delay in management increases the risk of uterine rupture, fetal distress and maternal morbidity. Yeah, so with this we have come to end of the discussion of this one. What is that, Bandel string? But it just I feel like I need to do the treatment part again due to some reason, not some reason, because this specifically didn't enter the head. Dehydration, ketosis, you can skip this, like you know right how to do that, just skip on to the next part. Or if there are timestamps, hopefully, I am not sure, I have not put in timestamps till now, but you can go to the next topic. But dehydration and ketoacidosis, IV ringer lactate. So this one, these were the contributory causes of this one. What is it, Bandel string? So correct that. Adequate analgesia, because pain is what the patient is feeling. So we want to avoid pain. Parenteral antibiotics we have already seen, and then caesarean section is the treatment of choice. And if uterine rupture is diagnosed, laparotomy with repair or hysterectomy. Yeah, now it is complete, because sometimes it is just reading out and it doesn't. It is incomplete. Yes. Next, coming to the next topic, precipitate labor. That is definition, etiology, risk factors, maternal risk, fetal risk, clinical features, diagnosis, and finally management. Definition: precipitate labor is defined as a labor where combined duration of the first and second stage is less than 3 hours. Combined duration of the first and second stage is less than 3 hours. It occurs due to abnormally strong and rapid uterine contractions. Leading to unusually fast delivery. Swiggy. Fast delivery. You got the joke, right? Swiggy. Fast delivery. Or Amazon. Anything. It is more common in multiparous women and is more commonly associated with uterine tachysystole. We got a new term. Let's check it out. We need to copy this. The final part, I will just copy it. I will copy this first and make this one. Yeah, so this one here and the next one too. Section before asking the next question. What is it? Bandel. Yeah, next what was it? Precipitate. Alternate PPT labor, precipitate labor. Yeah, uterine tachysystole. Uterine tachysystole. I will copy this and paste it here. Uterine tachysystole. Let's try to understand. It's a condition where there is excessive frequent uterine contractions during labor, typically defined as more than 5 contractions in 10 minutes. Average over 30-minute period. Excessive use of uterotonics, placental abruption, uterine overstimulation and hypertonic uterine contractions. Yeah. So fast delivery, that is what we need to keep in mind. Precipitate labor. Less than 3 hours, first and combined duration of first and second stage. Second stage meaning delivery of the fetus, and yeah. So and the third stage is usually with active management it is reduced to 5 minutes. So it is very quick, entire thing. Etiology, risk factor: hyperactive uterine contraction due to excessive use of oxytocin, excessive oxytocin stimulation or hypersensitivity to oxytocin. Low resistance of birth canal in multiparous women. It is like a slide, like not exactly, but that is what I can imagine. A placental abruption causing excessive uterine activity, previous history of precipitate labor and small or preterm fetus allowing rapid passage through birth canal. So these are the things. Maternal risks: excessive lacerations of the cervix, vagina and perineum due to inadequate stretching time. Excessive lacerations of the cervix, vagina and perineum due to inadequate stretching time. Postpartum hemorrhage. Let's look at the headings first. Excessive lacerations, postpartum hemorrhage, uterine inversion, uterine rupture, infection, amniotic fluid, embolism. So what is the main thing here? Fast delivery. And what are the risks? Lacerations, cervix, vagina, perineum due to inadequate stretching time. So it needs to be proper, physiological, expectant. everything needs to go in a particular way. If it doesn't go in a particular way, issues come up. If it is very quick, this is the thing. Extensive lacerations. Second one, postpartum hemorrhage due to uterine hypotonia following intense contractions. Uterine inversion due to excessive pressure and rapid expulsion of placenta. Excessive pressure and rapid expulsion of placenta. And uterine rupture, particularly, we have also seen this in Brandt-Andrews method. In case you have inappropriate, you are doing it less experienced, less skillful, inversion is a problem. Less timing is not right. In this particular case, timing is not proper, like the delivery of placenta. So this can occur. Uterine rupture, particularly in women with previous cesarean and grand multiparity. Infection due to lack of proper aseptic precautions in emergency delivery settings. And then finally, amniotic fluid embolism, that is due to rapid expulsion of the fetus. So these are the maternal risks. Now we have some fetal risks. Intracranial hemorrhage due to stress and rapid passage through the birth canal without proper molding. So same thing, it needs to happen in a certain way. If it doesn't, molding is not functional, no proper molding, and intracranial hemorrhage. Brachial plexus injury due to sudden delivery and uncontrolled head expulsion. Cord avulsion, mainly it is mechanical in this particular case. Cord avulsion and fetal distress due to, entire labor is mechanical, but still, cord avulsion and fetal distress due to rapid descent and forceful expulsion. Cord avulsion. Neonatal hypoxia if uterine hyperstimulation causes placental insufficiency. Neonatal hypoxia if uterine hyperstimulation causes placental insufficiency. Coming to the clinical features. Extremely rapid progression with cervical dilatation rate of greater than 5 centimeters per hour in multipara and greater than 3 centimeters per hour in nullipara. Extremely rapid labor progression with cervical dilatation rate greater than 5 centimeter in multipara, greater than or equal to 3 in nullipara. So how quick the dilatation is. So usually we know that this one is quicker in multipara, what is the labor duration and all that, but here we specifically looking at precipitate labor, it is much faster than that. Very strong frequent uterine contractions without adequate relaxation between the contractions. Severe maternal discomfort due to rapid cervical dilation. Severe maternal discomfort. Then fetal distress signs due to compromised placental perfusion. Fetal distress signs due to compromised placental perfusion. Next, coming to diagnosis. History of previous rapid labor. Clinical examination showing unusually fast cervical dilatation and descent of the fetal head. So it is like dilatation is quick and also descent is fast. Electronic fetal monitoring may show tachysystole with fetal distress. We have learnt about this already. So it is the number of contractions is very fast. It is number is high. Now coming to the management. So prevention, and then there is during labor and postpartum care. Most of these questions have management divided into various subsections like prevention, during labor, postpartum, and also maybe preparation of labor, something of that sort. So coming back to this particular topic, hospitalization of high risk women with history of precipitate labor. So that is one thing. So history of previous rapid labor is a important marker. A careful oxytocin administration and monitoring, because it is something tachysystole is a problem, and use of tocolitis like magnesium sulfate or beta mimetics in early labor to control uterine activity. During labor, controlled delivery of the fetal head, to prevent perineal trauma. Episiotomy to reduce uncontrolled perineal tears. Episiotomy, controlled delivery of the fetal head, and then IV hydration and pain relief. Finally, continuous fetal monitoring to detect distress early. So these are the things. During labor, controlled delivery of the head, episiotomy, IV hydration and pain relief, and continuous fetal monitoring. Then coming to postpartum care, monitoring for postpartum hemorrhage and uterine atony, inspection and repair of genital lacerations, and neonatal assessment of birth injury. So, these are the things: monitoring for postpartum hemorrhage and uterine atony, inspection and repair of genital laceration because it is happening quick and all that, and postpartum hemorrhage is one of the issues. Neonatal assessment for birth injuries, again because the labor is quick. Prognosis: with timely intervention and proper labor monitoring, the complications can be minimized, ensuring better maternal and fetal outcomes. Conclusion: precipitate labor is a high risk condition that requires prompt recognition and careful measurement. Proper prenatal assessment, hospital monitoring of high risk cases, and skilled intrapartum care can significantly reduce maternal and fetal morbidity. So, this one makes sense because this was understandable, good topic. So, now we are closing this and moving on to the next chapter, which is abnormal presentations and cord prolapse. Number 1, breech presentation, very important section, and there is another question too. I kept forgetting about it, the right occipito posterior or something. I tried to add it later in the future, but not right now. Maybe before the exams it will be there. It will be there before the exam, but not right now. Breech presentation definition: breech presentation occurs where the podalic pole, the buttocks or feet of the fetus, presents at the pelvic brim instead of the head. The fetal lie is longitudinal, but the presenting part is the breech rather than the vertex. It is most common malpresentation during labor. So, podalic pole is the presentation where podalic pole of the fetus presents at the pelvic brim instead of the head. This makes sense, right? The feet or the buttocks are presenting first rather than the head, because the head cephalic is the normal one, fetal high longitudinal, not transverse or anything, and it is just the opposite, not the vertex, opposite of vertex, 180 degrees. Incidence: this is a 10 marker, so even this has been included here. At 28 weeks, the incidence is approximately 20% and reduces to about 5% by 34 weeks, and at term it is 3 to 4%. So, as the more the earlier the gestational period, the higher the chance. That is what the principle is here. Spontaneous correction to vertex presentation often occurs by 34th week due to fetal movements, and breech presentation is more common in multiparous women due to lax abdominal wall and is found in about 10% of the cases. Coming to causes of breech presentation. Several factors contribute to breech presentation, which can be categorized into maternal, fetal and uterine. So, first one, prematurity. It is the most common cause as the fetus has more space to move in early gestation. That is number 1. Most common cause as the fetus has more space to move in early gestation, like lots of space, meaning you can, that is a bad one, meaning comparing space and earth and all that. But yeah, polyhydramnios. Yeah, polyhydramnios is promoting it, breech presentation, but oligo is it is something that is preventing it. So, breech with extended leg. Factors preventing spontaneous version, meaning coming back to its normal position. Breech with extended legs, frank breech. Yeah, so we need two varieties. So, it is down here, but still let's check here types of breech. Types of breech presentation. So, here you can see complete breech, incomplete breech and frank breech. This one, no, this one. Breech with extended legs, frank. Oligohydramnios, this one prevents spontaneous version, congenital uterine malformations, bicornuate or septate, and short cord or intrauterine death of fetus. So, these are the things that prevent spontaneous version: breech with extended legs, oligohydramnios, congenital uterine malformations, and short cord or intrauterine death. Favorable adaptations for breech. What favors? What puts it into the breech position? let's check this again. Okay, I just want to make sure what I said was right. Factors preventing, what does it mean? Probably it is not coming back to its normal. Yeah, so normal position, cephalic, yeah, it's correct what I said. Short cord and intrauterine death, because it's not coming back. So anything of that sort. Favorable adaptations for breech. Hydrocephalus, head, large head fits well into the fundus. Placenta previa, placenta blocking the lower uterine segment. So placenta itself is lower down, so the fetus feels better to lie in the upper aspect. So the head is, which is much bigger, meaning it is the first one to go out, right? So it is the rate limiting one. So that is up at the top near the fundus. Contracted pelvis or cornu-fundal placental attachment. Contracted pelvis or cornu-fundal placental attachment. Fetal abnormalities, trisomies 13, 18, 21. 13, 18, 21. Anencephaly, myotonic dystrophy and other neuromuscular conditions. So these are the fetal abnormalities. Trisomies 13, 18, 21. Undue mobility of the fetus, hydramnios, polyhydramnios, multiparity, that is lax abdominal wall. Hydramnios, excessive amniotic fluid and multiparity, lax abdominal wall. So these are the things we can talk about. We can talk about these things when we are discussing the causes of breech presentation. Number one, prematurity. The earlier the gestation, the higher the chance of this one, what is a breech. Factors preventing, so we had some like breech with extended legs, oligohydramnios, congenital uterine malformation, short cord. Favorable, we had hydrocephalus, placenta previa, contracted pelvis and fetal abnormalities like trisomies and anencephaly, myotonic dystrophy and undue mobility like with polyhydramnios, multiparity. So that one. And next, coming to the varieties, yes, types. So breech presentation are categorized into incomplete and incomplete based on the position of fetal legs. So the fetal legs are what we are looking at, and complete is the flexed breech. So then there is incomplete breech. Complete breech, thighs flexed at the hips and legs flexed at the knees. Thighs flexed at the hips and legs flexed at the knees. So this one is the complete breech. Let's take a look. The complete breech. This one flexed, thighs and this one. Presenting parts include the buttocks, external genitalia and the feet, common in multiparous women. Incomplete breech. Incomplete breech can be further classified into three varieties: frank breech, footling presentation and knee presentation. Number one, frank. Thighs flexed at the hips but legs extended at the knees. So this one is frank presentation. Only buttocks and external genitalia present at the brim, common primigravida due to good uterine tone. So this one is frank breech. Buttocks and external genitalia present at the pelvic brim, common in primigravida to good uterine tone. 21 minutes. Footling presentation. Thighs and legs partially extended. One or both the feet present at the brim. So footling is not here. Footling is here. This is the one, footling. Thighs and legs partially extended, causing one or both the feet present at the brim, more common in case of prematurity. Knee presentation. Thighs extended but knees flexed. What was it? Knee presentation, yes. Knee, I am not sure if it is here somewhere. Yeah, knee presentation is here. It's probably the fetal head and one of the knees. Yeah, this is the body, this is the knee. Knee presentation. Thighs extended but knees flexed, presenting the knee at the brim is a rare variety. So again, there is complete where everything is flexed, both the legs are flexed. Frank breech where hips flexed, thigh is flexed and legs are extended. Buttocks and external genitalia present at the pelvic brim, common in primigravida. And footling, thighs and legs partially extended, and knees, thighs extended but knees flexed. Coming to diagnosis of breech presentation, there is clinical, ultrasonography and radiological methods. Clinical diagnosis, there is abdominal, auscultation and vaginal examination. Abdominal, there is fundal grip, pelvic grip and lateral grip. What do we feel? So, fundal grip, so what is there at the fundus in breech presentation? The head is present. So, what do we feel? A hard globular mass, which is the head, is felt at the uterine fundus. This makes sense. Pelvic grip, a soft, broad, irregular mass, the breech is felt at the pelvic brim. A soft, broad, irregular mass is felt at the pelvic brim. And lateral grip, the fetal back is on one side and irregular limbs are on the other side. So, that is the lateral grip. So, these are the 3 grips of the abdominal examination. Auscultation, fetal heart sounds are heard at the higher level around the umbilicus. So, up higher around the umbilicus, so that is the auscultation. And vaginal examination, during pregnancy, soft irregular parts, the buttocks and sacrums are felt through the fornix. So, vaginal examination during pregnancy, soft irregular parts are felt through the fornix, buttocks and sacrum. And during labor, ischial tuberosities, sacrum and feet can be palpated. Ischial tuberosities, sacrum and feet, because the feet and the lower limbs, those are the presenting parts. Ultrasonography confirms the diagnosis of breech, detects the congenital anomalies and determines fetal attitude. Detects the congenital anomalies and determines fetal attitude. Assesses placental location, amniotic fluid volume and estimates fetal weight. So, 3 things: confirms diagnosis of breech, detects congenital anomalies and determines fetal attitude, assesses placental location, amniotic fluid volume and estimates fetal weight. Next, coming to radiological methods, rarely used today, but MRI is used to detect the pelvic capacity. So, this is something similar to the cephalopelvic disproportion, where MRI was used. Yeah, it was used, right? Yeah, it was, to check for pelvic adequacy. Next, coming to the mechanism of labor. So, mechanism of labor, we have seen it in the normal case, but in this particular case it is slightly different. Why? Because the engagement is with the different diameter and everything is different totally actually. So, labor in breech presentation involves the delivery of 3 major parts: the buttocks, shoulders and the head, each following cardinal movements similar to cephalic presentation. So, similar to it, but some things are different. Number 1, engagement. The bitrochanteric diameter 10 centimeters engages in oblique diameter of the feet of the pelvis. So, bitrochanteric diameter, let us see bitrochanteric. This is the bitrochanteric diameter 10 centimeters. This is engaged. Engages in the oblique diameter of the fetus. Descent and internal rotation. The anterior buttock rotates to the symphysis pubis. The anterior buttock rotates towards the pubic symphysis, anterior buttock. Lateral flexion, the posterior hip is released first, followed by the anterior. So, here this is something new, lateral flexion. So, let us take a look. Lateral flexion, in breech, yes. So, here you can see the presenting part and the, which one is it? Posterior one. So, anterior buttock rotates towards the pubic symphysis. Sorry, I will keep this here. Yeah, anterior towards the pubic symphysis, and then lateral flexion. The posterior hip is released first, followed by the anterior. So, the posterior hip is coming out first, followed, yeah, this one coming first, followed by the anterior. Then delivery of the trunk follows. This is down, and then shoulders. There is engagement bisacromial diameter, which is 12 centimeter, engages in same oblique diameter as the buttocks. And descent with internal rotation. Shoulders rotate, bringing the anterior shoulder under pubic symphysis. bringing the anterior shoulder under pubic symphysis, rotation. And delivery of the shoulders, the posterior shoulder is delivered first, followed by the anterior. Posterior shoulder delivered first, followed by the anterior. So, posterior comes first. This is not shown in this diagram, maybe a different diagram. Yeah. Anyways, posterior delivered first, then comes the anterior, and finally the head engagement suboccipito-frontal. So, was it the same one previously? Suboccipito-brachmatic. Yes, that was the one. It could be either engages in oblique diameter. So, that is the one, and internal rotation. The occiput rotates anteriorly. So, let us see delivery of the head. Occiput, yeah, occiput rotates anteriorly. Flexion and delivery, the head is delivered by chin, mouth, nose, forehead and occiput. Chin, mouth, nose and this one forehead anteriorly. Chin, mouth, nose, forehead and occiput successfully. Occiput is the last one. The occiput is still touching even if everything is out. Occiput is the last one. So, we have seen all the images, and now it makes much more sense what the mechanism of labor is in breech presentation. So, again the presenting three major parts. So, we are looking at delivery of three major parts. One is the buttocks, shoulders and head. So, we have three different headings: buttocks, shoulders and head, and each following different cardinal movements. So, one there is engagement, descent and internal rotation, descent and internal rotation here and internal rotation here. So, and then finally, and specifically for this we have lateral flexion for the trunk. So, for the hip, sorry. So, yeah, and for engagement for buttocks there is bitrochanteric diameter, which is 10 centimeter, engaging in oblique diameter of the pelvis, and anterior buttock rotated towards the pubic symphysis. Lateral flexion, the posterior hip released for, followed by the anterior, and delivery of the trunk. In shoulders, bisacromial diameter 12 centimeters, same oblique diameter as the buttocks, descent with internal rotation, shoulders rotate, bringing the anterior shoulder to the pubic symphysis. So, it is relation with anterior buttock with pubic symphysis, anterior shoulder with pubic symphysis. Delivery of the shoulders, posterior delivered first, followed by the anterior. Head engagement, the suboccipito-frontal engages in the oblique diameter, internal rotation, the occiput rotates anteriorly, and flexion and delivery, the head is delivered followed by chin, mouth, nose, forehead and occiput successfully. Last one is occiput. So, that is flexion and delivery, flexion and delivery. Yeah, so now it makes sense. Now it makes a lot more sense. The mechanism of labor. Coming to the complications of vaginal breech delivery, maternal and fetal complication. Maternal side, increased risk of operative delivery, because it is totally different compared to, totally meaning the headings and all are the same, but real life it is totally different. So, operative delivery increased risk, perineal trauma and episiotomy complications, and then postpartum hemorrhage due to uterine atony. Fetal complications, birth asphyxia, birth injuries, cord prolapse and congenital anomalies. So, birth asphyxia due to cord compression or delayed delivery of the head. Cord compression or delayed delivery of the head, that is number one. Birth injuries, fractures, femur, humerus, brachial plexus injuries, intracranial hemorrhage. So, fractures, brachial plexus injuries, intracranial hemorrhage. So, these are the things. Cord prolapse, more common in footling breech, cord prolapse. And then congenital anomalies associated with hydrocephalus, we have seen it already in trisomies. Methods of vaginal breech delivery, spontaneous breech delivery, assisted and breech extraction. So, spontaneous. So, these are different, mechanism of labor is totally different compared to the methods. So, spontaneous breech delivery, the fetus delivered by maternal expulsive efforts without assistance and not commonly preferred due to risk of complications. Assisted breech, fetus is allowed to descend naturally until the umbilicus is delivered, like half the trunk almost, after which the assistance is provided to deliver the arms and the head, assistance is provided. principles: never pull down, never pull from below, assist the pushing from above, key things, and ensure good uterine contractions for smooth delivery. So, never pull but push and ensure good uterine contraction. Breech extraction, the entire fetus is delivered by obstetricians manipulation and reserved for emergencies like cord prolapse or extended legs. So, these are the things. Coming to techniques for delivery of breech components. There is delivery of legs, delivery of arms and delivery of after coming head. So, these are the things, something different, totally different, meaning some maneuvers which is we need to learn separately. Number 1 maneuver, Pinard's maneuver, flexion and abduction of the knee to release the extended leg. So, we need to take a look at how it looks like. We know frank breech, how it looks like. So, let us look at Pinard's maneuver. Yeah, so here is an image, frank breech, Pinard's maneuver, done uterine manipulation to convert the frank breech into footling breech. So, frank is turned into footling. This is possible when membranes have ruptured entirely. So, frank is turned into footling. Now, look at this, flexion and abduction of the knee to release the extended legs, flexion and abduction, more separation, flexion and abduction of the knee. So, flexion and then abduction away from the midline. So, if this is the knee, more of flexion and abduction, like this is the midline, more of abduction. It's like legs are like this, abduction, adduction is this, abduction is this, in case you do not remember. So, if you look at from the midline, it is flexion, you can see over here, abduction is away from the midline to release the extended legs, and delivery of the arms, that is Lauset's maneuver, and then there is also classical method. So, Lauset's maneuver, rotating the fetal trunk to bring down the arms, Lauset's maneuver. Fetal head is held by the hip or bony pelvis and the fetus rotated through 180 degrees to deliver the shoulder and arm. And then fetus is rotated to the opposite direction so that the shoulder and arm are delivered through pubic symphysis. Now, it makes much more sense. So, it is rotating the fetal trunk to bring down the arms. Classical method, delivering the posterior arm first followed by the anterior. So, that is normally we have seen in the mechanism, posterior shoulder, yes, posterior shoulder, I was little bit, so, delivery of the posterior arm first followed by the anterior. Delivery of the after coming head. So, this one comes as a 3 marker, delivery of the after coming head. Why? How? Number 1, Burns-Marshall method, allowing the baby to hang by its weight while applying suprapubic pressure. So, it looks very interesting actually when you look at the diagram. So, here you can see how it is let loose and then free his mouth and suck him out, swing his head clear and let him hang until you can. So, that is A, let him hang until you can see the hair at the back of his neck. So, here you can see the hair, and then hold his feet, free his mouth and suck him out and swing his head clear. So, swing it and while applying, so all of it while applying suprapubic pressure. Forceps delivery using Piper forceps to deliver the head safely, Piper forceps, the Piper forceps. Marisou-Smellie-Viet maneuver, flexing the fetal head with fingers while applying traction on the shoulders. Suprapubic pressure is being applied. So, modified, we do not want modified, we want the original. Assistance is placed over here and middle finger is presses on the occiput and finger on his mouth. here. So, flexing the head with the finger while applying traction on the shoulders. Finally, indications for cesarean section in breech presentation. Number 1, fetal indication, maternal indication and obstetric indications. Number 1, fetal indications. There is prematurity, hyperextended fetal head. We have 5 more minutes. We can finish ECV too. There is C-section in breech. So, we have seen the normal without any kind of intervention. Intervention meaning invasive intervention. But cesarean section, why do we do it? In case fetal indication include prematurity, hyperextended fetal head. So, at the last moment, not even just at last moment, every time, anywhere. But it is hyperextended fetal head, footling presentation because there is a risk of cord prolapse, and fetal growth restriction or macrosmia. Maternal indications, contracted pelvis or pelvic inadequacy, previous cesarean scar or uterine scar, and placenta previa or other uterine anomalies, because like half the thing it is because of rupture, and this one is like so many things, uterine anomalies, abnormalities. It's better to go for cesarean. Cesarean section we have a separate question altogether somewhere down, that would help. Obstetric indications, fetal distress or non-reassuring fetal heart rate, failure of labor progression and cord prolapse. These are the 3 things: fetal distress or non-reassuring fetal heart rate, failure of labor progression and cord prolapse. Obstetric indications. And with this we come to the end of this particular topic, which is breech, which was very long but very interesting too. Coming to ECV, how is ECV important? ECV is a non-invasive obstetric method in which fetus is manually manipulated through the maternal abdomen to convert a non-cephalic presentation, usually breech or transverse lie, into cephalic presentation. So, a non-cephalic is made into cephalic. This is typically done in the 3rd trimester to increase the chances of vaginal delivery and reduce the need for cesarean section. So, we do not want cesarean section to happen to occur, we do not want that. So, vaginal delivery is what we want. So, that is why we are looking at ECV, external cephalic position, that is a non-invasive method because it is external, manually manipulated through the maternal abdomen. Role of ECV in management of breech presentation. ECV plays a crucial role in managing breech presentation by attempting to reduce the incidence of non-cephalic presentations at term and thus minimizing the risks associated with breech vaginal deliveries. Non-cephalic presentations, reducing the incidence of non-cephalic presentations, thus minimizing the risk. So, we have some roles here. Reduction goals: reduction in breech presentation, decrease in cesarean deliveries, improve the perinatal outcomes, cost effective strategy, when to perform. Number 1, reduction in breech presentation. ECV is successful in converting breech to cephalic presentation in about 65% of the cases. So, breech to cephalic, it is good, meaning it works, ECV works, that is what it is saying. Significantly decreasing the number of breech presentations at term. Decrease in cesarean deliveries. By converting the fetus to cephalic presentation, ECV reduces the need for cephalic sections, cesarean section, not cephalic sections. Like chop the head over. No. ECV reduces the need for cesarean sections. So, that is the goal. We want breech or anything else to be converted into cephalic. So as to avoid cesarean. Planned cesarean deliveries are often recommended for persistent breech presentations due to associated maternal and fetal risks. That is for persistent breech. So, we do not want persistent breech. Improved perinatal outcomes. Successful ECV is associated with reduced risk of perinatal morbidity and mortality. So, successful ECV reduced risk of perinatal morbidity and mortality compared to persistent breech presentations, which carry higher risk of birth trauma, cord prolapse and asphyxia. Cost effective strategy. ECV is simple, low cost procedure compared to expenses associated with cesarean section and the post operative care. So, that is why we want a low cost method. When to perform ECV? Typically done at 37 weeks of gestation or later. Earlier versions have higher risk, higher success rate, but greater chance of reversion to breech. Earlier versions have higher success rate but greater chance of reversion to breech. So 37 weeks is the best one. 37th week. Delaying ECV until term reduces the risk of preterm labor if complications arise. Yeah, we'll just, how many? This is somewhat huge. So let's finish it till here and then let's take a break. Yeah, delaying ECV until term reduces the risk of preterm labor if complications arise. ECV preferred before opting for cesarean section because it offers chance for vaginal delivery, minimizing surgical risk. ECV is preferred before opting for cesarean section because it offers a chance for vaginal delivery. Overall the same thing which is mentioned earlier, so we don't want this. Anyways, I'll stop here right now and take a break, and I'll continue after the break. Until then, even you can take a break or else jump on to the next section, but I would suggest you to take a break, especially if you are doing it at 2x. Yes. So let's continue. This is the third session, and we have reached almost 1/4 of ECV. Expected it to be much shorter, but it turns out to be quite big topic. Let's begin. Techniques of ECV. Let me drink some water. I didn't drink it. Techniques. Number 1, pre-procedural preparation. Number 1, assessment. Second one, fetal monitoring. Third one, informed consent. Next one, positioning. Next one, tocolysis. Number 1, assessment. Ultrasound is used to confirm fetal presentation, amniotic fluid volume, placental location, and exclude any congenital anomalies. So ECV, as we are, so coming back, it is a way to turn the breech into cephalic. So, but to do that, we need to know, we need to look at the location of how it looks like and all that, what the volume is, and whether it is actually doable. Yeah, with congenital anomalies and all, it becomes very difficult. So, in order to manage it properly, we are doing assessment, that is pre-procedural preparation. Next one, fetal monitoring. Cardiotopography is performed before and after the procedure to monitor fetal well-being. Then coming to informed consent. Risks and benefits are explained to the patient, and informed consent is obtained. Even for this particular procedure, though it is non-invasive, like most of the, even for, as long it is in the general examination phase, you can avoid proper the sheet where you get the sign and all that, but this is somewhat different and little bit more into invasive category, but not completely. It's non-invasive, but more than general physical examination, more than examination. It's a procedure. Positioning. The mother lies in supine position with slight head down tilt to relax the uterine segment. Positioning of ECV. Maybe that's a good way to search. Positioning of mom in ECV. Mother's positioning is maybe this is the ECV. Yeah, so here you can see turning breech babies, spinning babies. The mother lies in supine position with head down tilt to relax the lower uterine segment. Tocolysis. Tocolytic agent like terbutaline may be administered to relax the uterus and improve the chances of success, because whatever you are doing, right, whatever your manipulation you are doing, it should properly transmit into the uterine cavity. It can't be just like the uterus is rigid or contractile, in a contractile state, higher tone, and it won't pass in. You can't manipulate directly. So that is what. Again, assessment, fetal monitoring like CTG, informed consent, positioning, supine, head down tilt, and tocolysis. And steps of the procedure. Step 1, palpation and orientation. Step 2, disengagement of breech. Step 3, forward or backward roll. And then, this one is from the textbook, sorry about this. Yeah, so palpation and orientation. So the fetal position, then finally completion of version. So this is proper procedure. Fetal position is carefully identified through abdominal palpation. So we do those grips and all that, right? The fetal head and breech are located. And the direction of version is planned. So we know where the feet is, where the head is. Disengagement of the breech. Practitioner gently lifts the breech out of the maternal pelvis to allow free movement of the fetus. So if it is engaged, it can't move. It is engaged already, like just in engagement, then marriage, wedding. So engagement is like it is fixed, you can't move it. But if you want to disengage, and then you can move it easily. That's what it is. And instead of head, it is the breech, like buttocks or feet or whatever, or the knee. Forward or backward roll. The fetus is rotated in a forward roll, most common, like this, or backward roll like this, depending on the ease of movement. In forward roll, the practitioner pushes the breech upward. In forward roll, the practitioner pushes the breech upward while simultaneously guiding the head downward into the pelvis. Do you understand? Yeah, like this. One sec. ECV forward roll. ECV forward roll, somersault. Yeah, so here you can see physician feeling the head and rump of the baby external, turning the baby, applying pressure externally. So here you can see forward roll, the breech is disengaged and simultaneously pushed upwards. So forward roll. So the forward rolling of this is the breech rolled forward, and this one is head is pushed towards the pelvis. The vertex is pushed towards the pelvis. That is forward roll. And what is it? Or backward roll. Backward roll is just the opposite. Diagram reference. We have seen the diagram reference. The flowchart outlines the fetal monitoring is conducted before and after ECV, and tocolysis may be used to improve the success rates. Completion of version. The version is complete when the head engages into the maternal pelvis in cephalic presentation. So, head engagement in maternal pelvis, that is what we want, rather than breech being engaged. And post procedural care. Again, we will look at the headings. Palpation and orientation, to get the orientation right. Disengagement of the breech, like make sure the breech is disengaged. Forward or backward roll, like forward roll, the fetus rolled forward, meaning like this, the buttocks come up and the head comes down, and then engage the head, and that is the completion of version. Post procedural care. Head fetal heart monitoring. CTs is repeated to ensure fetal well-being. Fetal well-being should be maintained. Anti-D immunoglobulin administered to Rh negative mothers to prevent isoimmunization. Anti-Rh, this one immunoglobulin. Anti-Rh. Anti-D immunoglobulin. And observation, the mother is observed for a few hours to monitor complications like preterm labor, rupture of membranes or vaginal bleeding. So, mother is observed for a few hours to monitor complications. Coming to the success rates and predictors of successful ECV, 65%. Higher success rates are seen in complete breech presentations. So, this guideline works really good for complete breech. Non-engaged breech. So the first step is eliminated, not first step. Second step is not required because it is not engaged. Adequate amniotic fluid. So, good room for fetal movement. Posterior placenta reduces the obstruction to fetal manipulation. That is posterior placenta, and multiparous women due to more relaxed abdominal and uterine muscles. Multiparous women. So, multiparous, even this one is faster. What is it? The duration of labor is much less, and also in this particular case it is much more relaxed, the uterine muscles, abdominal muscles. So, it is much easier to do the ECV. Contraindications of ECV. So, you can't just do it. There are some contraindications, absolute and relative. So, if the placental location, that is what we are looking at, if it is near the os or placental abruption, the bleeding and all that, avoid ECV. Ruptured membranes or oligohydramnios. So, there is not enough room to move, and then fetal distress or non-assuring fetal heart rate. So, better to avoid such movements. Uterine anomalies. What if you can't move in the first place? Yes. Multiple pregnancies, you can't, there is not enough space. Previous cesarean sections, risk of uterine rupture, but in this particular case, maybe after the delivery of the first baby. Previous cesarean section, risk of uterine rupture. So, that is another one. Relative contraindication, severe preeclampsia, IUGR, nuchal cord entanglement. What is this? For all of this, I need to check it out. Should I copy this? Let me copy this. Uterine tachysystole was for which one? Not required, leave it. You have seen it, right? Not required. Google Docs. Why relative contraindication of ECV. The procedure used to turn breech into this one. It involves hypertension, placental dysfunction, and it can make the uterus more irritable and prone to complications like placental abruption or fetal distress. Intrauterine growth restriction. placental insufficiency, all that, blood flow, nuchal cord and or cord entanglement, nuchal cord, cord wrapped around the neck, or cord entanglement, cord compression. This can lead to acute fetal hypoxia, bradycardia, or even placental abruption, and suspected fetal anomalies. Like there are so many. Yeah, now coming to the complications. So, yeah, we have last two parts, complications and benefits. How much time did it take? It took around 10 minutes. It will take probably 5 more. Complications, though generally safe, ECV is associated with some complications like fetal distress, premature rupture of membranes, placental abruption, uterine rupture, and failure of version. Number 1, fetal distress caused by cord entanglement or placental abruption. Immediate cesarean delivery may be required if persistent. So, that is number 1. Cord entanglement, because you are like moving it like a ball inside the tummy. So, anything can happen. Number 1 is the cord, the wire that is connecting the fetus to the mother, that can get entangled. A placental abruption. So, like if it is too much of if there is this one, what is it? So, what was it? Cord entanglement. Yeah. In case of cord entanglement, meaning the cord gets entangled, there is fetal distress. Yeah, that is what I meant. Placental abruption, like in case there is bleeding and all that, and placenta is dysfunctional, fetus can get into distress. Immediate cesarean delivery may be required. Manipulation may cause rupture of membranes, increasing the risk of preterm labor. Placental abruption, separation of placenta due to manipulation leading to bleeding and fetal compromise. Uterine rupture, rare but possible in cases of previous uterine scars. And failure of version, even with a successful version, there is a chance of reversion to breech presentation. So, again it can go back into the previous state. So, again complications, fetal distress, premature rupture of membrane, placental abruption, uterine rupture, and failure of version. Benefits: reduces cesarean section rates, improves vaginal delivery rates, cost effective, safer alternative to vaginal breech delivery. Number 1, by converting breech to cephalic, ECV significantly reduces the likelihood of planned cesarean delivery, because persistent breech is a problem, and what is the way? Cesarean is the way, but ECV prevents that. Improved vaginal delivery rates, successful ECV increase the risk of chances of normal vaginal delivery. Like it is painful though for the mother, so that is a negative, which has fewer complications than cesarean. Cost effective, it reduces the need for surgical intervention and associated hospital stay and post operative care. Yeah, so yeah, it is not invasive. Safer, meaning the whatever comes after is not non-invasive. Safer alternative to vaginal breech delivery. So, breech presentations carry higher risk of birth trauma and fetal distress during vaginal delivery, which can be avoided with successful ECV. So, birth trauma and fetal distress, which can be avoided with successful ECV. And with this we come to the end of the topic ECV, and we have 2 more topics under abnormal presentations and cord prolapse. Yeah, so how many more remaining? Yeah, not many meaning it is going to take quite some time, but overall this is a very good chance we will finish obstetrics before the exam, like very well before. Maybe this session, no, not possible this session, maybe the next session or a session after, which is not that far. And actually this today is 24th March, but I am going to upload this much far into the future. So it is going to be much closer to the exam. So obstetrics would be done for the viewer just before the exam. But anyways, it doesn't really matter because the website is still up and you can still go through the website. The content is all there. I am just going through this and making it easier for you as well as for me. It is much easier for me to learn these things and all of that if the camera is focused, because I won't miss anything. That is the key. But if I do it by myself, I might miss something. but since I know that somebody is watching and learning as I am learning, there is less tendency for me to miss things, and which is a very good thing when learning on camera, and also the somewhat teaching the Feynman method. Yes, let's stop there and come back to deep transverse arrest. DTA is a condition during labor where fetal head is deeply engaged in the pelvic cavity. Fetal head is deeply engaged in the pelvic cavity and the sagittal suture of the fetal head lies in the transverse bispinous diameter. Deep transverse arrest. Transverse, something is transverse there. Otherwise, usually everything is longitudinal, right? So, here what is transverse? Sagittal suture of the fetal head lies in the transverse bispinous diameter. So, bispinous diameter, what are we talking about? Bispinous diameter of the mother. So, again, let's look at an image. Deep transverse arrest. We need to look at how the head looks like. So, yeah, so transverse bispinous diameter. So, there are the spines. So, the spine is on the either side. So, bispinous diameter. So, in this diameter even the sagittal suture is present, which is not the case usually. Usually what happens, the occiput is facing the, it should eventually reach the pubic symphysis. That is what one of my friends spoke about this. Probably even he watches these videos. Yeah, so he spoke about this one specific fact. Whenever the labor process happens, eventual goal is the occiput to reach the pubic symphysis, so that the occiput can easily slip like as it touches the pubic symphysis. So that is the key landmark what we think about. So in this particular case that is not happening, and what is the diameter in that particular, that is just the opposite. The sagittal suture is not like this in that particular thing, in that it is like this. You understand, occiput is here and the frontal part is here and the sagittal is like this. Here it is like this, which is transverse, and it is arrested in the transverse state and it is deep into the pelvic cavity. So, deep transverse arrest. Now, we have understood this particular term. Despite full dilatation of cervix, there is no progress in the descent of the head even after 30 minutes to 1 hour, which is a really long time. This condition presents as a failure of internal rotation of the fetal head leading to obstructed labor. This condition presents as a failure of internal rotation of the fetal head. So, internal rotation is not happening, leading to obstructed labor. Yeah, so that is what internal rotation for why? Because you want the occiput to reach the pubic symphysis region, meaning you want it to face the pubic symphysis. Pathophysiology. Again, let's look at the definition again, because that can definition is super important. Is a condition where during labor where the fetal head is deeply engaged in the pelvic cavity, deeply engaged, and sagittal suture of the fetal head lies in the transverse bispinous diameter. Despite full dilatation of cervix, there is no progress in the descent even after 30 minutes to 1 hour. Failure of internal rotation of the fetal head leading to obstructed labor. Coming to pathophysiology, in normal labor process, the fetal head undergoes internal rotation to align with the AP diameter of the pelvis, facilitating descent and the delivery. In DTA, the fetal head remains transversely oriented due to incomplete or absent internal rotation. So, it is in transverse position. So, no point, it is not moving forward. This arrest commonly occurs in occiput transverse positions, but may also occur in oblique occiput posterior positions. So, normally meaning this particular topic, it is occiput transverse, meaning occiput in a transverse position, but can also occur where oblique occiput posterior, meaning it is occiput is in the posterior segment of the pelvic cavity. Where is it? Yeah, oblique posterior, occiput posterior arrest. So, here you can see what is it. This this should be the occiput. Occiput is this, and this is in an oblique manner. This is understandable, and it is in the posterior direction. So, this is anterior of the side of the pelvis, posterior side of the pelvis, and this is posterior oblique, and this is the posterior oblique arrest. So, that can also occur. The failure of rotation leads to mechanical obstruction, preventing the fetus from descending further through the birth canal. leads to mechanical obstruction preventing the fetus from descending further through the birth canal. The transverse position of the sagittal suture suggests that the largest diameter of the fetal head is misaligned with the pelvic outlet, making it, this one is, I think I should take this up reasoning, but anyways, in case somebody is just going through this without watching a video or assistance from other resources, this will help the reasoning aspect, the reasoning section, the reasoning block. Causes of DTA: faulty pelvic architecture, deflection of the head, weak uterine contractions, laxity of pelvic floor muscles. Number 1, faulty pelvic architecture, prominent ischial spines that hinder the occiput fetal head rotations. So, that is number 1, prominent ischial spines that hinder the fetal head rotation, that is pelvic architecture, it comes under that. Flat sacrum and converging sides of the pelvis which obstruct the fetal movement. So, they are somewhat like probably, though it is not mentioned here, I am thinking of android pelvis or something of that sort. Converging side walls, flat sacrum and all that. Specifically, are we looking at, let's check, are we looking at android pelvis or platypus or something of that sort? Yes, it is android pelvis. A flat sacrum or convergent side walls of the pelvis suggest android pelvis. So, narrow pelvic inlet, prominent ischial spines, convergent pelvic side walls and flat sacrum. So, that is what we think about in case of deep transverse arrest. And deflection of the head, inadequate flexion of the fetal head increases the diameter that must pass through the pelvis leading to arrest. So, at the end we know, right, like as it goes through, as the descent is happening, flexion is also something that the baby needs to undergo, flexion of the head. But if that is not happening, what happens? The diameter which should pass through is increased. It is more information from the mechanism of labor chapter. Question: weak uterine contractions. Insufficient contraction force may prevent the fetal head from completing its internal rotation and descent. And laxity of pelvic floor muscles. A lack of muscular tone reduces the guiding forces necessary for internal rotation of the fetal head. So, that is the final point. Lack of muscular tone reduces the guiding forces necessary for internal rotation. So, these are the 4 key things: faulty architecture, deflection of the head, flexion not happening, uterine contraction not proper, laxity of pelvic floor muscles. Next, coming to diagnosis. So, there are some examinations and some monitoring aspect. So, number 1, abdominal examination, 27 minutes. I am very happy looking at this, like so far. We were there somewhere, we did not even start pediatrics, then we finished pediatrics. Now, we are almost at the end of obstetrics, and within no time we will be done with gynec, and then the rest of the subjects, hopefully. Yeah, hopefully everything would be covered, should be covered, everything should be covered, yes. At least from my side I will try my best. Actually, I won't be able to give my 100% after the exams. Even during the exams I can try somewhat recording and all that, because it's beneficial, but after the exams there is no what do you say, incentive for me to continue doing this, because this is, I am not actually writing anything or getting an output from my head, meaning I am not bringing it out like I am doing right now, because it's super important writing this exam. So, learning it like this actually helps, but I am not going to be using this anywhere else in the future, specifically this MBBS finals. So, anyways, we'll figure out a way. Hopefully, if somebody lends out a helping hand or anything, it should help out a great deal. Yes, diagnosis of deep transverse arrest. We are deviating a lot. I am deviating a lot, but I am releasing some key information regarding this website and all of that, which should help. Yeah, coming to the diagnosis. Yes, clinical diagnosis based on abdominal and vaginal examination, abdominal, vaginal, and then there is pelvic assessment and monitoring. So, we were in the heading, we just spoke about this. Yeah, it is just this and this, nothing else, but then something pelvic assessment comes, then monitoring also comes. Fine. So, but these are non-clinical, these are clinical. I'll drink some water. Sorry about that. Abdominal examination. A fetal head is deeply engaged in the pelvis. It comes from the definition itself. Little to no descent of the fetal head despite strong uterine contractions. Yeah. Vaginal examination. The sagittal suture of the fetal head lies in transverse bispinal diameter of the pelvis. Comes from the definition. The anterior frontal is palpable, indicating incomplete rotation. So, anterior frontal shouldn't be palpable. Interesting. Prominent ischial spines may be felt. So, that is a key it is a key feature of android pelvis. Caput succedaneum and molding may be present due to prolonged labor. So, we have learned this already, and prolonged labor is one of the causes, or obstructed labor. Pelvic assessment. A faulty pelvic architecture may be identified during examination, contributing to the arrest. Monitoring. CTG may show signs of fetal distress if the arrest is prolonged. CTG may show signs of fetal distress if the arrest is prolonged. So, that is one thing. Coming to the management. So, if vaginal delivery is not safe, if vaginal delivery is safe, there are different things we can go about doing. Then finally, there is operative vaginal delivery considerations. Then there are complications too. So, looks like quite huge. Like just by looking at the DTA, something DTA, yeah, looks very small. But when you actually go to the management, oh my god, it looks huge. We'll finish it off. Management of DTA depends on fetal condition, pelvic assessment, and the availability of skilled personnel. Fetal condition, pelvic assessment, and availability of skilled personnel. The goal is to ensure safe delivery while maintaining maternal and fetal risks. Minimizing, not maintaining. Minimizing the, did I say maintaining? Shouldn't maintain risk, minimize it. Maternal and fetal risk. If vaginal delivery is not safe, when vaginal delivery poses significant risk due to large baby or inadequate pelvis, a caesarean section is preferred mode of delivery. Indications of C-section. CPD, mismatch between the fetal size of the fetal head and maternal pelvis. Second, size of the fetal distress. Signs of fetal distress or non-reassuring fetal heart rate. That is another one. Failure of attempts to rotate the fetal head. So, rotation of the fetal head is not happening. Maternal exhaustion or other complications like preeclampsia. So, these are the four things: CPD, fetal distress, can't rotate the head, maternal exhaustion. CPD, fetal distress, can't rotate the head, other complication, maternal exhaustion. When is it found safe? So, here there is some reasoning. C-section eliminates the need for risk of traumatic delivery in cases where pelvis is insufficient for vaginal birth. So, the vaginal birth, it's mainly dependent on the architecture and all that. So, if that itself is unsafe, the normal passage is not proper, better to do C-section. That is what they are talking about here. If vaginal delivery is found safe, okay, we can do vaginal. When the fetus is in good condition, pelvis is adequate, and the following methods could be used, may be used. Number 1, Ventouse. Number 1, manual rotation and application of forceps, and forceps rotation and delivery with keel and forceps. So, these are the three things, and specifically forceps and Ventouse, all this is mentioned separately. It's a separate 5 marker, very important, which I have mentioned, which is mentioned in the instrumentation section. Where is it? Somewhere, operative obstetrics, I guess. Somewhere over there. So it's there. Number 1, Ventouse, vacuum extraction. 3 idiots. I think it's the same thing. Vacuum cup is applied to the fetal scalp to assist with the head rotation and descent. Caution: excessive traction force should be avoided to prevent scalp injury, cephalometoma, or intracranial hemorrhage. So, Ventouse is beneficial for mild arrest, but contraindicated if excessive traction is required. That is one thing. Manual rotation and application of forceps. Forceps have you seen? So, it is the same thing as this one. What is it? Forceps delivery. ventouse also I'll show, ventouse OBG. So here you can see the ventouse, this is forceps, this forceps, this one suctioning and all that, vacuum, and forceps. Yeah, so manual rotation and application of forceps, the fetal head is manually rotated to align with AP diameter of the pelvis. I hope you can imagine, because we are talking about DTA, still we are still in DTA. So it was what, sagittal suture along with bispinous. It was not, it shouldn't be bispinous, it should be AP diameter. Sagittal suture should be along the AP diameter. Once rotation is achieved, forceps is applied to assist in the delivery. So once rotation is achieved, so manual rotation is done, forceps is used to achieve the delivery. Steps. Operator inserts their hand into the vagina and gently rotates the fetal head. So that is manual rotation. After successful rotation, forceps are applied to guide the head through the birth canal. So that is another thing. Forceps rotation and delivery with keel and forceps. Let's look at keel and forceps, because it's not normal forceps. Here you can see the parts. Maybe it comes in the practicals or something. So better to know. This is Simpson's, not in this particular case. Here there are handles, lock, shank, blades. So keel and forceps. Should we open this? No need. Keel and forceps are specifically designed for rotational deliveries due to their sliding lock and minimal pelvic curve. Sliding lock and minimal pelvic curve. Sliding lock is here, and the minimal curve, that is what they are talking about, probably. The forceps are applied to the fetal head and gentle rotation is performed to align the head with the pelvic outlet. Forceps are applied to the fetal head and gentle rotation is performed to align the head with the fetal to the pelvic outlet. So rotation also, so gentle rotation also, apply rotate to align the head with the pelvic outlet. Advantages: effective in cases with persistent ossipotransverse positions, persistent, so repeatedly, provides controlled rotation and traction. So with this, there is the lock, helps in controlled rotation. Requirement: the technique should only be performed by skilled obstetrician due to the risks associated with rotational forceps. So what are the risks associated with? Yeah, I'll show this, because anything can happen. It can come in practicals, and then you don't know what are the risks associated with rotational forceps, specifically the keel and forceps. But their carries, minimal pelvic curve, unlike other shallow pelvic curve, making them ideal for rotating the head in case of, however, they don't follow the birth canal. Sliding lock mechanism, high risk, vaginal perineal trauma, uterine rupture, postpartum hemorrhage, general things. So for rotational deliveries, keel and forceps are the instrument of choice. Maybe we need to go in much more detail as to keel and forceps. Explain parts properly. Rotational deliveries, malposition and all that. There are blades, yes. Shallow pelvic curve, unlike more forceps, have minimal pelvic curves. Okay, we understood that. Parallel blades, nearly parallel and strongly converging. So keel and forceps, blades parallel, nearly parallel, these are parallel and strongly converging, both of them converge. Here, yeah. And cephalic curve, the helps cradle the fetal head and distribute pressure evenly to reduce the skull trauma. Interesting. Sliding lock, we have seen the lock already. So there is fixed lock, which helps in what? So it makes it easier to apply forceps in cases where fetal head is asynclitic and needs adjustment. The sliding lock helps Align the blades properly around the fetal head without excessive force, and the shanks longer and straighter than those in other fossa, allowing deeper application in the birth canal. Where are the shanks? Yes, for deeper application. Interesting. Handle. The handle is sturdy, provides good grip. Where is the handle? Oh, nice. Good. Yeah, next, coming to operational vaginal delivery considerations. Operational delivery for DTA should be performed by a highly skilled obstetrician with experience in rotational deliveries. Yes. Continuous, because we have seen the risks right here. Risks, yes. Continuous fetal monitoring is essential to detect any kind of fetal distress during the procedure. If operative delivery is unsuccessful or complications arise, a cesarean section should be performed immediately. So, operative delivery, what is this here? These things and all that. No, wait. Yeah, with this. So, we have listen. This should be performed by. So, it is. We are talking about operative vaginal delivery. Yes, operative vaginal delivery. If it is unsuccessful, C-section is immediate. Coming to complications of DTA, maternal prolonged labor due to maternal exhaustion, leading to maternal exhaustion, increased risk of PPH due to uterine atony. Is uterine atony seems like it is a separate section. Maybe over there, in case it is insufficient, if we don't have enough of information about uterine atony, then I'll go about searching it here. Otherwise, for now, uterine atony is a very important concept. But if you want to go in more detail, that is later during PPH section, PPH chapter. Perineal trauma from forceps delivery or difficult manual rotation. High likelihood of cesarean section if vaginal delivery fails. So, that is another thing. So, prolonged labor leading to maternal exhaustion, increased risk of PPH due to uterine atony, perineal trauma from forceps delivery or difficult manual rotation, and higher likelihood of cesarean section if vaginal delivery fails. All of them make sense. Fetal complications, fetal distress due to prolonged labor and compromised blood supply. Yeah, because it is in deep transverse position. Birth injuries such as brachial plexus, cephalometoma, intracranial hemorrhage, because the passage it is stuck there. Caput succeedium due to prolonged. This one is stuck there. This one, why? Because it is not going properly. It is not. Why is this the case? I feel like I will remember this, but it's very hard to remember without conceptual understanding as to why this is the case. Why in DTA? So, these are the things, these are small things that matter. Yeah, why this is happening? I wouldn't have searched this if the video was not on. Do you understand? Yes. So, brachial plexus, yeah, we know what it is. There is forceful traction or improper rotational force during forceps delivery. Interesting. Cephalometoma, okay, with respect to forceps application, very interesting. Vacuum extraction, excessive suction, and even in the textbook they don't mention all these things. So, we need to specifically go out of our way to search all these things. So, considering that, I think it's better if I make a Google Doc. Yes, what is it? DTA, because this thing was very nice. Excessive force can cause vessel rupture. Imagine, I do so much of online lectures, not lectures, learning thing, videos, 4-hour sessions, 3-hour session, hour session, 10-minute videos and all that. And then they ask me, looking at this, some kind of tough question, I won't be able to answer. They ask why, not in Singhé. Not a previous year question. Caput succedaneum or molding due to prolonged pressure on the fetal head. Caput succedaneum and molding due to prolonged pressure on the fetal head. And this one, that one makes sense. Neonatal asphyxia if the arrest is prolonged and not managed properly. Yes. Prolonged prognosis, not prolonged. When managed appropriately, DTA can have favorable outcomes for both mother and the baby. Early identification and presence of skilled personnel significantly reduces the risk. Prognosis is better when manual rotation or forceps assisted is successful, and C-section ensures maternal and fetal safety when vaginal is not happening. So, with this we come to the end of DTA, which was surprisingly huge. I didn't expect that I didn't expect that at all. Yeah, so how many minutes remaining? We have 10 more minutes. I think it took a really long, yeah, it was a really long topic. But if somebody who knows it exactly, meaning they will just like tap, they'll just go through it full speed. But it won't have this, you won't get the same learning experience as you're getting in this particular session, wherein when I'm there, you are there, both of us are learning, and I'm trying my best to learn it in the best possible way so that I remember. I think it's called by a specific name, like that is a Feynman is separate thing. It's called elaborative learning. Should we take a detour? No, we are finishing this corporal level. Elaborative learning, that is the meaning wherein you like dig in everywhere. So that is what we are doing here right now. In case something doesn't make sense, we just look it up on ChatGPT or the internet. In case you want to look at diagrams, we are looking at through Google, because even when it comes to textbooks and all that, like anyways I'm going there. Anyways, we have a lot of time. It's what time is it? 1:19. We have time till till what time am I ready to stay awake? I drank coffee and I can stay awake for a really long time. So let me elaborate on elaborative learning. Yeah, so in the textbook you have something like just one diagram and you are forced, you feel like I need to understand it through this. But with this, you can just go through here, just copy this, paste it here. You have so many diagrams, you can understand with whichever you want. The research papers here, you want to read more, you can go here. You can elaborate on whatever you are learning. Every word is linked to something else. You don't understand something, we have ChatGPT, and this is not even paid, it's free. Such an amazing resource, but now it is 4.0 because we don't use it much, right? So such an amazing way to learn. And yeah, this you can actually, if this thing expands, not just previous year questions, if this thing includes all the possible variations of questions that could be asked, it would be a really good way to learn rather than just looking at the textbook, because this is linked to the internet. You can't link the internet to the textbook, but you can link this to the textbook. You can link this to the research. You can link, for example, I was thinking of doing this, but it is going to take a lot of time. Something like linking every particular paragraph or something and putting a star here and linking that to a research paper. And in case you want to learn more about this paragraph, you can just click this button and you go to that research paper, you read more about it in case you want to, or else copy whatever the abstract is, put it into ChatGPT, understand this paragraph much more through the lens of research. I was thinking in that direction, and hopefully it will work. That is I feel the best way to go about expanding this particular resource, but I don't know what the future is going to be like. Plans might change, things might change, anything can happen. Yeah, coming back to the definition. Yeah, I was not planning to do 4-hour sessions. I am back doing 4-hour sessions. So anything can change. Definition: cord prolapse is an obstetric emergency where umbilical cord descends below the presenting fetal part after the rupture of membranes, leading to cord compression and impaired fetal oxygenation. It requires immediate intervention to prevent fetal hypoxia and death. So yeah, so cord prolapse, let's look at an image. Cord prolapse. So here you can see the presenting part is here and this is in front of the presenting part. So it makes it much more easier to visualize this thing, whatever this, and you can compress it much more easily, and because of that, what fetal distress can occur. Yes, impaired fetal oxygenation. It requires immediate intervention to prevent fetal hypoxia and death. Again, it's obstetric emergency where umbilical cord descends below the fetal presenting fetal part after the rupture of membranes. Because can you look at the image? This thing, whatever this you are looking at, can happen only after the membranes rupture, because this thing is present inside the membranes, amniotic membrane. It is inside this. Only after the rupture it can come out. So even the rupture of membranes is included into the definition. Leading to, what does it lead to? Cord compression. So compression of the cord, of course, and impaired fetal oxygenation. Coming to types of cord prolapse: occult cord presentation and overt cord prolapse. Occult prolapse: the cord lies beside the presenting part but is not palpable on vaginal examination. So, it is lies next to the presenting part, but not palpable on vaginal examination. Occult meaning not visible. Yeah, funny thing, it is about occult, mainly related to the demons and all of that. So, occult, yes, side note, wait, occult, I will just show you, probably it will go to that this one, demons, ghosts and all that, occult, see, yeah, can you see this, it is magic and all that, see. So, it is about that, you can't see it. Yeah. So, it may be detected on ultrasound or suspected due to fetal heart rate abnormalities. So, since it is beside, you can't see it, you can't, meaning you can't palpate it, it's you can estimate it using, not estimate it, visualize it using USG, ultrasound or fetal heart rate abnormalities. Cord presentation, the cord slips below the presenting part and it is palpable through the membranes. So, the cord slips below the presenting part and it is palpable through the intact membranes. So, when the membranes are intact, so here we talked about after the rupture. So, before the rupture it is palpable through the intact membranes because it is below the presenting part and it is cord presentation, that is type 2. And overt cord prolapse, the cord is visible outside the vulva or directly lies inside the vagina after the rupture of membranes. So, this happens after the rupture of membranes. So, these two are somewhat similar, this one is occult, you can't feel it, you can't palpate it on examination, but it is seen through ultrasound or fetal heart rate abnormality. Just like in ghost YouTube channels and all that, they detect go for ghost detection and all that, and they don't use normal, you can't see those ghosts, right, they use those ghost detect meter, just like that. In this particular case, the ghost detect meter is this ultrasound, is that ghost detect meter, ghost detect, not detect meter, detector, sorry, detectometer. Let us see if there is something like detect. We can't turn this one to a weird stream, we are learning. Incidence, that is what, if you study at night, that is one of the issues, you lose track, and also it is very late, right, this is the third session we are talking about, the third hour. Incidence occurs in 1 in 300 pregnancies, more common in multiparous women due to lax uterine tone. Incidence decreases with increased use of elective cesarean sections in malpresentations. So, occurs in 1 in 300 deliveries, more common in multiparous women due to lax uterine tone. Increased incidence decreases with increased use of elective cesarean sections in malpresentations. So, in case you do cesarean section, the incidence decrease in case of malpresentation, because that is what is more, it is a predisposing factor. Yeah, it is a predisposing factor. See, so anything that prevents proper engagement of the presenting part in the lower uterine segment increases the risk of the cord slipping past it. So, engagement is what? For example, this is the pen and this is getting engaged into the cap. So, in case this is something like this is the cord, sorry, this is the cord, and this one is, and this engagement is not happening. Why? Because this cord is, you get the point. This is somewhere in the middle, if the engagement is not proper, somewhere here, head is here, cord is getting engaged, cord is getting inside. Hey, how will that happen? It is somewhere outside. That is what. So, cord is slipping past it. Fetal factors, malpresentation, transverse lie, breech presentation, especially in footling and compound breech. In case of prematurity, smaller fetuses have more space for cord descent. Smaller fetuses have more space for cord descent, because if this is not the pen, that is this is a smaller pen, the cap is much big. So, high tendency of this wire to enter the cap rather than the cap the pen might also go in, but this has a higher chance of entering this. Multiple pregnancy increased risk of malpresentation. So, these are three things, the three fetal factors. Maternal and uterine factors. Contracted pelvis prevents proper engagement of the presenting part. Contracted pelvis prevents the proper engagement of the fetal part. That is one thing. Contracted pelvis, CPD, contracted cephalopelvic disc, that is something else. Contracted pelvis, let us take a look. Meaning contracted, that is obvious, I think. It's the same thing, simple contracted, narrow inlet, a reduced space at the ischial spine and contracted outlet. Yeah, so general translation, contracted. Hydramnios, excessive amniotic fluid creates space for cord displacement after rupture. Excessive amniotic fluid creates space for cord displacement after the rupture. Placental, oh, wait. So we are at the third. We'll finish this off, then we'll take a break. Anyways, we wasted quite some time. It's not actually wasting, but still, we spent in things that were non important. Placental factors. Low lying placenta or marginal cord insertion. So, the closer it is to the os, the higher chance of it passing through that. Iatrogenic causes, artificial rupture of membranes before the fetal head is engaged. And then manual rotation of the fetal head, ECV and IPV. So, these are few other things. So, ARM, ECV, ICV. Again, fetal factors, malpresentations, foot-link compound breach, prematurity, multiple pregnancies, maternal and uterine factors, contracted pelvis, polyhydramnios, placental factors, polyhydramnios, more space for cord replacement after the rupture. Yeah, more space for this thing to happen. Placental factors, low lying placenta, iatrogenic factors, artificial rupture of membrane, manual rotation of the fetal head, external cephalic version and internal podalic version. And with this, we are going to take a break right now. And this is a very short, it is somewhat big. Yeah, so now after the break, we are going to look at the diagnosis of cord prolapse, and then we are going to continue further. And until then, I think better take a break so that we can refresh. mic was off. Yeah, welcome back. Yeah, this is going to be the final session of this particular video, but most likely I'll continue recording because I'm not tired yet. Though the way I speak, it might sound a bit slurred. That is fine. I'll get used to it. I want to do more of this, so hopefully everything would be fine. Wherever it is, 3 hours 6 minutes. I can just imagine how it would look like. Continuous 10-minute videos, 15-minute videos, then suddenly 4 hours back to back. That would be crazy. Let's begin. Yes, diagnosis of cord prolapse. Occult cord prolapse, cord presentation, overt cord prolapse, and then there is ultrasound. Number 1, occult, can't see, so not palpable, right? So persistent, suspected when there is persistent fetal heart rate deceleration on electronic fetal monitoring, CTG, cardiotopography. So that is one thing, and also ultrasonogram can also be used. And then cord presentation, diagnosed by palpating the umbilical cord through the intact membranes through the vaginal examination. Then there is overt cord prolapse, overt cord, meaning it is just after rupture of membranes, direct visualization of the cord at the vulva, palpation of the cord in vagina with pulsations felt in the fetus, if the fetus is alive. The palpation of the cord in the vagina with pulsations felt if the fetus is alive. So this one is self-explanatory, both of these explanations. Yeah. Moving on to the next one, ultrasound, used to confirm cord presentation or fetal viability if pulsations are absent. So this is done only when the pulsations are absent. This is something new. So otherwise, go for pulsation, go for CETG, cardiotopography, and direct palpation also works, especially for cord presentation, and if palpation is one thing, and direct visualization in case of overt cord prolapse. Important note: avoid handling or pulling the cord extensively as may cause vasospasm, worsening fetal oxygenation. Fetal heart rate auscultation or ultrasound should be done before declaring the fetal death. So fetal heart rate or ultrasound should be done. Prognosis. So before going on to the management, probably I think I need to put this down way down into the after the management. But anyway, since we have it here, let's finish it off. Prognosis: fetal risk, maternal risk, acute fetal hypoxia due to mechanical compression of the cord, that is one thing. Vasospasm of umbilical arteries from exposure to air or excessive handling, that is something else. We need to keep in mind. Vasospasm of umbilical vessels when you expose it to air, and fetal hypoxia. Perinatal mortality 15 to 50% if it is not diagnosed, and 5 to 10 if it is diagnosed and delivered within 10 to 30 minutes. High risk in vertex presentation, as the cord is more likely to be compressed against the pelvis. Yeah, cord prolapse. Maternal risks. Emergency cesarean section risks include risks, hard to pronounce, increased anesthesia related complications, higher blood loss, and infection risk. So increased anesthesia related complications, higher blood loss risk. So that is another something else. So key determinant of fetal prognosis is the time between cord prolapse and delivery, and cord prolapse detection and delivery, as prolonged compression leads to irreversible hypoxia. Coming to the management. So there is anticipation, early detection, emergency management, and definitive management. Key headings: anticipation and early detection, internal examination after premature rupture of membranes, especially in cases of malpresentations, twins, hydramnios, or unengaged fetal head. So that is one. So internal examination after premature rupture of membranes in case of these things: malpresentation, twins, hydramnios, unengaged fetal head. Surgical induction should be performed in operation theatre settings to prepare for emergency C-section if required. So that is the second point. So under the cord prolapse, anticipated and early detection, internal examination after premature rupture of membranes, and for these things, malpresentation, twins, hydramnios, polyhydramnios, unengaged fetal head. These are the 4 key things: malpresentations, twins, hydramnios, unengaged fetal head, because these are the things that predispose to cord prolapse. Yeah, I was thinking of something. There is something that I am missing. I am not telling. So that was the thing. In these conditions, increased risk of cord prolapse, and surgical induction for emergency cesarean. Then emergency management, specifically in cesarean, particularly emergency. How do you manage? What is the management like? Relieve cord compression while preparing for delivery. Relieve cord compression while preparing for delivery. So bladder filling technique. Foley's catheter is inserted and 400 to 750 ml of saline is infused into the bladder. This lifts the presenting part, reducing cord compression. So Foley's catheter insertion, number 1, 400 to 750 ml of saline into the bladder. So Foley's catheter inserted, one thing, insert the Foley's catheter and start adding the volume. This lifts the presenting part, reducing cord compression. I wish there was a way to imagine this bladder filling technique in cord prolapse. Maybe there is something on the internet that can help us in cord prolapse. Yeah, this is the thing. The dorsal position, if this thing is filled up, like here it is looking umbrella, but in the dorsal position, see how it looks like. It can actually help. Depending upon the positioning, it will help, like filling up this one, bladder filling, using Foley's catheter and 400 to 750 ml. And the manual elevation of presenting part, gloved hands are placed inside the vagina to lift the fetal head off the cord until delivery. So that is another thing. So mainly we are looking at ways to relieve the cord compression. That is for the second heading. Emergency management. Postural management, exaggerated Sims position, left lateral with wedge under the hip. Sims position. Yeah, wedge under the hip. Yeah, exaggerated Sims. And then there is Trendelenburg or knee chest position. So we have seen this already, to reduce cord compression. Knee chest, where is it? Yeah, knee chest. Trendelenburg, knee chest position. Yeah. So then there is minimizing cord handling. Avoid excessive manipulation to prevent spasm. Minimize cord handling. Cord handling. Avoid excessive. Yeah, so you don't want to touch it. See, this cord, somewhere they mentioned, even by exposure to air it can get vasospasm. Imagine if you touch it, what will happen? Crazy. Oxygen IV fluids, administer oxygen by face masks and initiate IV fluids to optimize fetal oxygenation. So these are the things, mainly goal to relieve the cord compression. Number 1, bladder filling technique. Second, manual elevation of presenting part. Third, postural management. We have Sims position, Trendelenburg, knee chest position. And then there is minimizing Trendelenburg or knee chest position, minimizing cord handling and oxygen IV fluids. Finally, the definitive management, if the baby is alive, if the baby is dead. If the baby is alive, C-section, immediate vaginal delivery. So C-section is preferred in most cases, best choice when the fetus is mature and viable. Avoid unnecessary delays in transferring the patient for surgery. So these are the 2 things. So best if fetus is mature, viable, unnecessary delays are avoided. Vaginal delivery only feasible. If head is engaged, delivery must be attempted using forceps or ventouse, vacuum extraction. We already know how this is done for which one was it? DTA or breech. Yeah, no, it was for DTA. Yes, I remember it is for 1 second. So what was it? It was it was for DTA. Breech was something else. The management is different. That and all these things are ventouse, forceps and all. Maybe it is. I can't actually. I need to go through it. It is fine. So forceps and ventouse. How can you use ventouse and forceps for? You can't use this. You can't use these unless one of the methods where you suction the head. like this, middle finger on the occiput and suctioning the head out as you take it out. Maybe somewhere over there they mentioned suction in one of the photographs, maybe somewhere over there, but other than that I doubt. But this is for detail. We are just spilling over into other topics, but forceps and ventouse for immediate vaginal delivery. When talking about what topic is this, cord prolapse, and fetal, if the fetus is in breech presentation, delivery may be done by breech extraction in expert hands. The fetus is in breech presentation, delivery may be done by breech extraction in expert hands. If in transverse lie, internal version is followed by breech extraction. So, internal version, then breech extraction. So, that is for transverse lie. So, we saw if the head is engaged, if the head is this one cephalic, if it is cephalic, if it is breech, and if it is transverse. Longitudinal lie, these two things, and transverse lie, this one. Internal version followed by breech extraction. If the baby is dead, allow spontaneous delivery to occur. No C-section is required unless maternal complications arise. Flowchart for management decision making based on fetal status. Yes, we have this here. And immediate vaginal delivery if possible, or C-section if indicated. First aid measures like bladder filling, manual elevation, positioning techniques. We have seen all of this already. With this, we come to the end of the topic cord prolapse, and also we are done with this big section on abnormal presentation and cord prolapse. There are many more questions, but these are the most repeated ones. So, better to know this thoroughly. And in this session, we have 38 minutes more, 39 minutes. So, we have learnt it in depth. We have understood it thoroughly. Maybe there is more, but this is for exams. Next, coming to a new topic, obstructed labor. It is a condition in which, despite strong uterine contractions, the progressive descent of the presenting part is arrested due to mechanical obstruction. So, despite strong uterine contraction, the progressive descent of the presenting fetal part is arrested. Obstructed labor due to mechanical obstruction. So strong contractions are happening. The descent is arrested due to obstructed labor. This may result from issues in the fetus, the birth canal, or both. Fetus, birth canal, or both, making further labor progression impossible without intervention. Incidence. In developing countries, the incidence of obstructed labor is about 1 to 2% in referral hospitals. It is more prevalent in areas with limited access to prenatal and obstetric interventions. Coming to the causes of obstructed labor. So, there is fault in the passage, which is the maternal cause, fault in the passenger, which is the fetal cause, which are the fetal causes, and we are going to look at each and every one of them. So, bony obstruction. So, this is from maternal side, from the mother. So, bony obstructions and soft tissue obstructions. So, bony obstruction, cephalopelvic disproportion, that is number 1, contracted pelvis, that is number 2, and secondary contracted pelvis. Cephalopelvic disproportion, contracted pelvis, secondary contracted pelvis. The fetal head is too large for the maternal pelvis. The fetal head is too large for maternal pelvis. And second one may be congenital or due to conditions like rickets or pelvic fractures. Rickets or pelvic fractures. So, that is number 2. And then there is seen in multiparous women due to pelvic floor laxity. That is another one. So, first one, the fetal head is too large for maternal pelvis. We have seen this already. Contracted pelvis may be congenital or due to conditions like rickets or pelvic fractures. And then secondary seen in multiparous due to pelvic floor laxity. Let's understand both of these. What each of these mean. What each of these mean. Contracted abdominally reduced this one. Congenital rickets, pelvic fractures can cause CPD, obstructed labor. but has functionally inadequate due to pelvic floor laxity. So, eventually it has become like that due to pelvic floor or previous birth trauma seen in multiparous women, pelvic floor muscle weakening, previous pelvic trauma, prolonged labor. So, we are done with bony obstructions. Now, coming to, we are still in fault in the passage, maternal causes. Soft tissue obstruction, cervical dystocia, vaginal and vulval tumors, prolapse of the cervix and vagina, and uterine anomalies. Number 1, cervical dystocia caused by cervical fibroids, scarring from previous surgeries and rod ligament fibroids. Cervical dystocia. Dystocia, abnormality in cervix, fibroids, scarring, broad ligament fibroids. Yes, that one is fine. So, what are the possible soft tissue structures which are there? That is what we are thinking about. Vaginal vulval tumors obstruct the passage of the fetus. Vaginal or vulval tumors. Prolapse of the cervix or vagina during labor. And then there is uterine anomalies such as bicornuate uterus or septate uterus, bicornuate or septate, that is the uterine anomaly. So, bony obstructions we are done. So, for CPD, contracted pelvis, secondary contracted pelvis, we understood both of these, not actually, secondary pelvis that was once normal, it was once normal, but here it is completely, here it is once normal. You read it, but I didn't read that thing. Like I had some idea, but I didn't read this particular thing. But eventually it becomes this one, due to pelvic floor laxity. What's remaining? So then coming to soft tissue, cervical dystocia, fibroids, scars, vaginal or vulval tumors, prolapse of the cervix or vagina during labor, and uterine anomalies. Fault in the passenger, so fetal causes. So, malpresentations and malpositions, congenital malformations of the fetus, large baby. So, malpresentations, malpositions, this transverse lie, bro presentation, occipito-posterior position, compound presentation and locked twins. So, these are some of the causes in fetal causes. Transverse lie, fetus lies horizontally in the uterus. So, what are we talking about again? We are talking about obstructed labor. So, fetus lies in the horizontal. So, can it pass? No, it won't. Fetal head should be engaged. Bro presentation, fetal head is partially extended. So, it is not flexed. Flexion is important, right? Occipito-posterior position. So, occiput in the posterior direction. What do we want? Occiput to be in the anterior position. Why? Because it needs to slip past the pubic symphysis, which is a key landmark. The back of the head is facing the maternal spine, which shouldn't be happening. Compound presentation, more than one fetal part presents simultaneously. This is very interesting. Maybe we need to look at an image just for curiosity's sake. Compound presentation, OBG. Look at that. Crazy. Locked twin, when both the twins interlock, they prevent descent. Locked twins. Maybe something like, I can imagine it, but I don't know how to explain it, something like this, like a puzzle pieces. Congenital malformations of the fetus, hydrocephalus, fetal ascites, double monsters. Hydrocephalus, accumulation of fluid in fetal brain enlarges the head. Accumulation of fluid in the fetal brain enlarges the head. That is one. Fetal ascites or tumors that enlarge the fetal abdomen. Ascites or tumors. Double monsters, conjointins. It's hard for them to obstructed labor again. Obstructed labor. Faults in the passenger, that is what we are talking about, and we have spoken about the different presentations, malpositions and all. Second, we are talking about congenital malformations. So, hydrocephalus is one, ascites, tumors and all that. Hydrops fetalis, even that is included here. double monstrous conjoined twins, and then large B macrosmia, so seen in diabetic mothers. We have half an hour more, we can easily cover it up. This one, yeah, we can finish this one also. Then we come to very important sections. Yeah, so clinical features, maternal symptoms, maternal signs, fetal signs. Can there be fetal symptoms? No, because why? Because the fetus can't talk. Yes, clinical features. Maternal symptoms, prolonged labor. So that is what the mother complains about. Labor does not progress despite strong uterine contracts, severe pain and anxiety, persistent intense pain due to uterine overactivity. Why? Because obstructed labor. It's not moving forward, it's obstructed. Definition again. Despite strong uterine contraction, the progressive descent of the presenting fetal part arrested due to mechanical obstruction. So there's lot of pain, anxiety, exhaustion, dehydration. I'm tired, I can't do it more, I need some water, but she can't drink it because she is really tired. Yeah, inadequate fluid intake, and then there is vomiting, accumulation of lactic acid and ketones due to prolonged muscular exertion. That is another thing. Maternal signs. So signs, what you elicit, what you see as a medical doctor. Pathological retraction ring, Bandl's ring, visible or palpable transverse groove between the upper and lower uterine segments, indicating obstructed labor. So that is one thing, we have seen this already previously. Bladder distension, bladder becomes abdominal organ due to compression between the presenting part and the pubic symphysis, causing difficulty urination. Let us look at the cross section, sagittal section of pelvis, pregnant. So here you can see how this one is there here, and this one comes down and all that, and here there is compression of this, and this one comes up, crazy, this one becomes an abdominal organ. Bladder distension, and then there is caput succedaneum and molding, swelling and overlapping of fetal skull bones due to prolonged pressure, and genital tract trauma. Vaginal tears or uterine rupture may occur due to prolonged labor. That is another thing. So these were the maternal signs: pathological retraction ring, bladder distension, caput succedaneum and molding, and genital tract trauma. Then comes the fetal signs: non-reassuring fetal heart rate patterns, absent fetal movements and palpable fetal anomalies. Number 1, non-reassuring fetal heart rate patterns. Bradycardia and decelerations may indicate fetal distress, absent fetal movement suggestive of fetal demise in prolonged cases. And then there are movements low, heart rate low, palpable fetal anomalies, hydrocephalus, fetal tumors and all that. Complications: effects on the mother, effects on the fetus. Effects on the mother, immediate effects, remote effects, and there are effects on the fetus. So effects on the mother: exhaustion, dehydration, yes, metabolic acidosis due to lactic acid, muscular exertion, genital sepsis from repeated vaginal examinations, instrumental interventions, rupture of uterus due to excessive pressure, postpartum hemorrhage from uterine atony or genital trauma. Uterine atony, repeating again, very important. We are going there, we are reaching there in a few moments. Please wait. Very excited for uterine atony. Yeah, again, immediate effects include exhaustion, whatever was mentioned here, metabolic acidosis, genital sepsis, rupture of uterus, postpartum hemorrhage. Then remote effects: genitourinary fistulae and vaginal atresia or secondary amenorrhea due to Sheehan syndrome. So pituitary necrosis from lack of blood, right? Blood is getting lost. So because of that, less blood for the pituitary. That is what. Remote effects: genitourinary fistula, vesico-vaginal fistula or recto-vaginal fistula, either front or back, anteriorly or posteriorly. So those are remote, like for somewhat into the future. Coming to effects on the fetus: asphyxia. So what are we talking about again? Obstructed labor. it is hard to lose sight of the bigger picture. So, it is obstructed labor we are talking about, and then we are talking about, we are done with effects on the mother, we are talking about effects on the fetus. So, effects on the fetus include asphyxia, acidosis, intracranial hemorrhage, infection. Asphyxia number 1, prolonged labor causes hypoxia due to interference with uteroplacental circulation. Acidosis resulting from prolonged hypoxia and lactic acid accumulation. Intracranial hemorrhage, supermolding of the fetal head, or instrumental trauma may cause bleeding, especially in preterm babies. Supermolding of the head or instrumental trauma may cause bleeding, especially in preterm babies. Then coming to the infection, ascending infections may occur leading to sepsis or intrauterine fetal death. Why infections occur? Repeated this one, instrumental interventions, vaginal examinations and all that. So, all of these things. Again, asphyxia, we know why it occurs, uteroplacental functioning has problems. Acidosis, we know why it occurs. Intracranial hemorrhage, we know why it happens, because of instrumental trauma, supermolding, and infections, we know why. Management of obstructed labor, we have time. So, the goals of management are to relieve obstruction, prevent maternal and fetal morbidity and control complications. Relieve obstruction, prevent maternal fetal morbidity and control complications. Number 1, prevention. Next one, intermediate management. Finally, we have definitive management. Definitive, we have some good stuff, and then we also have postpartum. So, prevention, antenatal care, intrapartum monitoring, antenatal care. Identify the risk factors, CPD, macrosmia, malpresentation. So, we remember, so again obstructed labor, the causes from here, CPD, macrosmia and all that, other, you can write everything, bony obstruction, so soft tissue and all that, that comes under antenatal. So, antenatal care, monitor fetal growth and pelvic adequacy with ultrasound. So, that is antenatal care. Next, coming to intrapartum monitoring, use of partograph to monitor labor progress. Partograph, timely intervention if labor is prolonged despite good contractions. So, labor is getting prolonged, but contractions are happening. What do? We need to look at this obstructed labor, that could be a possible cause. Next, coming to immediate management, preliminaries, correct dehydration and acidosis, antibiotic prophylaxis, bladder management, blood group and cross matching. So, number 1, correct dehydration and acidosis, IV fluids, sodium bicarbonate. So, IV fluids, ringer lactate or normal saline to correct fluid and electrolyte imbalances. Ringer lactate or normal saline to correct fluid and electrolyte imbalances, and then sodium bicarbonate for severe acidosis. So, this one, right, it is getting mother is getting exhausted, no water and all that, and acidosis. Why? Because too much of exertion. Antibiotic prophylaxis, repeated interventions, examinations, ceftriaxone, metronidazole to prevent genital tract sepsis. Bladder management, catheterization to relieve bladder distension to reduce the risk of bladder rupture, because bladder is going up and up because of the obstruction. Again, where was it? Bladder distension. Bladder becomes abdominal organ due to compression between the presenting part, the baby that is coming out, and the pubic symphysis. And the baby, so pushing, and this one goes up, very sad. And then there is blood grouping, cross matching to make sure that risk of postpartum hemorrhage, like if that happens, you have potential blood. Next, coming to repeating, correct dehydration, acidosis, antibiotic prophylaxis, we know why. Bladder management, we know why. Blood grouping, cross matching, we know why. Definitive management. So, what could we do? Vaginal delivery, C-section, like always. Vaginal delivery, how? If possible and safe, go with it. So, we are going with vaginal delivery if it is possible and safe. So, what are the options for us available? Forceps assisted delivery, Destructive procedures for dead fetuses. Forceps assisted, if the fetus is alive and head is low, forceps may be used. So, obstructed labor, fetus is alive, vaginal delivery is safe, let us do forceps assisted delivery. So, what directly can you do it? No, something, it is obstructed, right? So, what do we do? Symphysiotomy may be performed in resource limited settings to widen the pelvis. That is one. Destructive procedures for dead fetuses, craniotomy, decapitation to reduce the fetal head size and allow delivery, used for vaginal delivery, used when vaginal delivery is possible but the fetal is dead. Destructive procedures are avoided if fetus is alive. They are only considered when the fetus is dead and vaginal delivery is the safest option for mother. So, depending upon the analysis, risk benefit analysis. Caesarean section, most preferred. Indication, fetal distress, non-assuring fetal heart rate, reassuring fetal heart rate, CPD, malpresentation, failed vaginal delivery or attempts, or prolonged labor despite good contractions. Risks, infection, PPH, injury to surrounding organs, neonatal sepsis if performed after prolonged labor. So, that is something we need to keep in mind. Infections and postpartum hemorrhage. So, basically the risk of this one, caesarean section, along with that prolonged labor. Because of that we moved on to this, right, C-section. So, because of that there could be neonatal sepsis. I am feeling sleepy a little. How many time do you have? How much? We have 20 minutes approx. So, we will finish this off, then I will take a break, some break, then I will continue, I will come back. You will be able to see the time, how much of break I took. Maybe you can time it too for yourself. Postpartum hemorrhage, postpartum management. So, we have seen what we do. In case possible, vaginal delivery, in case not possible, caesarean section, if it is safe and all that, vaginal, and we do forceps assisted and then symphysiotomy because it is obstructed labor. Destructive procedure where fetus is dead, craniotomy, decapitation, and finally C-section. We know, we write everything and then we know the risks. Postpartum management, monitor for postpartum hemorrhage, uterine atony is common after prolonged obstructed labor. Inspect for genital trauma, examine the uterus and birth canal for rupture or tears. Antibiotic therapy, continue antibiotics to prevent postpartum infections, and psychological support. Provide counseling for mothers experiencing trauma from complicated deliveries. So, postpartum PPH, genital trauma, antibiotic therapy and psychological support. With this, we come to the end of this particular discussion on this particular topic, obstructed labor. This was the main one. Then there is shoulder dystocia, which is also very important. So, shoulder dystocia, something related to the shoulder, right? So, we have some manuals and all that. It looks huge, but actually it is can't really tell actually. When you look at it for the first time, you feel it is doable, then it will take ages to finish. Drink some water. Then during the revision I can watch these videos only rather than reading the textbooks and all. Then I can hear my own voice and my voice will ring in my head during the exams. Definition: shoulder dystocia is an obstetric emergency characterized by the failure of fetal shoulders to deliver spontaneously after delivery of the fetal head. So, it is an obstetric emergency characterized by the failure of fetal shoulders to deliver spontaneously after delivery of the fetal head. Do you understand? Head is already delivered, now you can't deliver the shoulders. We remember the mechanism of labor. So, just before restitution, what was it? Restitution, right? It was like the shoulders should be delivered after the head is delivered. Forget about restitution. So, if the shoulders are not delivered, it is a problem. It occurs when the anterior shoulder becomes impacted behind the pubic symphysis, maternal symphysis pubis, or less commonly posterior shoulder is obstructed by the sacral promontory. So, when the anterior shoulder becomes impacted behind maternal pubic symphysis, or less commonly when the posterior shoulder is obstructed by sacral promontory. So, we know why it is anterior, because it is anteriorly placed near the behind the maternal symphysis pubis. Why is it posterior shoulder? Because it is near the sacral promontory. If either of them are impacted meaning stuck there, then it is shoulder dystocia. This requires specific maneuvers to release the shoulders and facilitate delivery. So, previously we have learned some maneuvers in breech. Even over here we have some more. So, let us learn each of them. Incidence. Overall incidence of shoulder dystocia ranges from 0.2 to 1% of deliveries. More common in cases of fetal macrosmia and in women with diabetes or history of shoulder dystocia. Yes, coming to risk factors. So, we have 9 risk factors, and then we will also learn about the complications, fetal and maternal complications, and then prevention strategies and all. Yeah, first one, risk factors. History of previous shoulder dystocia. This is the case with so many other things. Previous pregnancy, same thing, now also same thing. Fetal macrosmia. So, size is big, so that is why I can't come out. It's like big shoulders. To do this one, shoulder raises, lateral raises. Fetal macrosmia. Fetal weight greater than 4.5 kilos increases the risk. Maternal diabetes, so this can cause this. So, fetal fat deposition, not muscle deposition, contributing to macrosmia, and obesity, BMI greater than 30 kg per meter square increases the risk due to excessive maternal soft tissue and around the birth canal. Prolonged first or second stage of labor indicates CPD or poor fetal positioning. First or second stage of labor, CPD. I am feeling sleepy. Anyways, we need to manage. I want to stay up till 6 or 6:30 or something, meaning doing this. Yeah, let us see if it is actually doable, if I can manage it. Since I said it now, I will have to. Yeah, multiparity. Post maturity. Wait, this was the one. Birth after 42 weeks may result in larger fetuses with reduced amniotic fluid, increasing the risk. Birth after 42 weeks may result in larger fetuses. So, post term, reduced amniotic fluid. So, what are we looking at? Shoulder dystocia. Yes. Multiparity. Multiple prior births may weaken pelvic structures, affecting the mechanics of labor. Multiple prior births may weaken pelvic structures, affecting mechanics of labor. So, that is also important. Multiple prior births, multiparity. Instrumental delivery, mid pelvic forceps or vacuum assisted deliveries can precipitate shoulder dystocia. So, instrumental delivery is another thing, and anencephaly, lack of fetal head size, increases the chance of shoulder infarction. So, again, history of previous shoulder dystocia, macrosmia, diabetic mother, obesity, soft tissue deposition and all that. Progression, prolonged first or second stage, indicate CPD, poor positioning, post maturity. The post maturity is greater than 42 weeks and reduced amniotic fluid and all. Multiparity, weakening of pelvic structure and mechanics, like normal mechanism of labor, that is not happening. And instrumental delivery, mid pelvic forceps or vacuum assisted deliveries can precipitate shoulder dystocia. And then anencephaly. Overall, it is fine, doable, can remember. Lack of fetal head size, there is no head. Complications, there is fetal and maternal. Fetal complications, number 1, asphyxia, number 2, brachial plexus injury, number 3, fractures, number 4, hypoxia, hypoxic ischemic encephalopathy, then neonatal death. Number 1, asphyxia, delay in delivery may lead to hypoxia and brain injury. Delay in delivery may lead to hypoxia and brain injury. Then there is brachial plexus injury. Stretching of brachial plexus nerves can lead to Ehlers palsy or clump case palsy. Stretching of brachial plexus nerves. Erbs or Klumpke's palsy. Fractures. Clavicle or humerus fractures are common due to traction forces. So, this thing is not passing through. So, all the possible things that can happen: prolonged labor, hypoxic ischemic encephalopathy, prolonged hypoxia, neurological impairment, neonatal death, rare but possible in prolonged delay. So, most of it is because of prolonged labor. Asphyxia, same thing. Brachial plexus injury because of stretching. So, this is the only thing where it is mechanical, but rest of it, even this one is mechanical. Fractures, brachial plexus, so musculoskeletal, these two. Rest of them, hypoxic induced ischemic encephalopathy and neonatal death, all the rest 3 are due to prolonged labor. Maternal complications. PPH is number 1, genital trauma number 2, bladder and urethral injuries number 3, sacroiliac joint dislocation number 4, psychological impact number 5. So, all of these, again, shoulder dystocia is what we are talking about, and PPH is seen 11% of the cases due to uterine atony and genital trauma. This uterine atony is coming up next after a few questions. Last question remaining. After this, there is one more, and after that, we are going to PPH. There we will find uterine atony, the final mafia boss. Genital trauma. Cervical lacerations, perineal tears, vaginal tears, uterine rupture may occur during manipulations, and then all these things. So, shoulder dystocia, we are doing some kind of maneuvers and all that. So, all of these those things can occur. And bladder urethral injuries may occur due to prolonged pressure or instrumental delivery. Sacroiliac joint dislocation due to excessive force during delivery. Sacroiliac joint, excessive force. And psychological impact, the traumatic experience can lead to postpartum depression or PTSD. So, this is one more thing. So, overall, again, PPH, genital trauma, bladder and urethral injuries, sacroiliac joint dislocations, and psychological trauma. Coming to prevention and prediction, how do you prevent it? Antenatal screening, ultrasound to detect macrosmia, CPD, gestational diabetic control to prevent macrosmia in the first place, tight glycemic control. Elective cesarean section recommended in cases of suspected macrosmia, especially in diabetic mothers. Why? Again, we are looking at the complication of not doing this. Like eventually leave it there and shoulder dystocia occurs after the head is delivered, shoulders are not coming out. We are looking at treatment. Prophylactic induction of labor, early induction in high risk pregnancies may reduce the risk of shoulder dystocia. So, that was the fourth point. So, prevention and prediction, antenatal screening, gestational diabetes control, elective cesarean section, and prophylactic induction of labor. Diagnosis. So, clinical diagnosis, turtle sign, fetal head delivers but then retracts against the perineum, resembling a turtle pulling into itself. Sounds very funny, but not funny. Yeah, like this, retraction, like this. Shoulder becomes impacted and contractions continue to push the head forward, stretching and damaging the nerves. Brachial plexus injury can also occur there. Failure of spontaneous shoulder delivery, difficulty delivering shoulders after head emerges despite normal traction. And then failure of fetal descent, the shoulders remain stuck despite contractions. So, turtle sign, failure of spontaneous shoulder delivery, failure of fetal descent. Then there is management. There is immediate management. Immediate management. So, it is prolonged labor, right? So, we need to lessen the time duration. So, we need to finish it off quick, finish of the process of labor somehow. So, we have some maneuvers which are right around the corner. The following maneuvers are used subsequently until the shoulders are delivered. How much time do I have? 6 minutes. Can we finish all this? Yes, we can. If not, we'll continue. We'll keep moving forward until we finish shoulder dystocia. No problems. Initial steps. Call for help. Shoulder dystocia requires multidisciplinary team including obs, anesthetists and pediatricians. Instruct mothers to stop pushing, reduce the uterine contraction to prevent further impaction. Avoid fundal pressure. Fundal pressure worsens the impaction and should never be used. So stop pushing. Ask mother to stop pushing. You don't push. Call for help. Primary maneuvers. Yes, finally the maneuvers. The price of being here till now, almost 4-hour mark. What's the price? The price is McRoberts maneuver. Should we read it first? Yes, we need to. Mother's thighs are sharply flexed onto her abdomen. We can see it. And then this flattens the sacral promontory. Can you imagine it? If you close your eyes, you want the sacral promontory flat, because usually it is not flat in females, it is curved, and it increases the AP diameter of the pelvis. Can you imagine it? It is curved, it is one thing. If it is curved, it's like this, but it's flat, it becomes like this, and this thing increases. If it is flat, this thing increases. Effective in 90% of the cases. First line maneuver. Yes, suprapubic pressure. Apply pressure just above pubic bone just to dislodge the anterior shoulder. Use downward and lateral motion to rotate the shoulder into an oblique position. Can be used in conjugation with McRoberts maneuver. So suprapubic pressure just to make it oblique. As we are moving forward, I think it would be a great idea to go back into the, where was it, mechanism of labor, normal labor. Yes, better to go over here and take a look here. Principle, this one, yeah, internal rotation. So internal rotation, this one we know already, just for this one, yeah. So the anterior shoulder slips with this thing first and with the, followed by posterior shoulder, completing the delivery. So where were we? Obstructed labor, yes. So what was it? What was I trying to talk about? So anterior shoulder should slip. And specifically we want it in the oblique position, downward and lateral motion to make it into an oblique position, and can be used in conjunction with McRoberts. So you can see the nurse over here, nurse or the doctor doing the McRoberts maneuver. Suprapubic pressure with flexion of this thing and making sure the thigh, the shoulder is in the oblique position. So we have completed the primary maneuvers. Next I want to secondary maneuver. Wood screw maneuver. Wood screw. Rotate the posterior shoulder. Let's rotate the posterior. So this here. Okay, where is it? Yeah. Don't directly pull it like this. Rotate the posterior shoulder. Sacral promontory posteriorly placed. Posterior shoulder posteriorly placed. Do you understand? Yeah. In a corkscrew motion 180 degrees, this reduces the bis acromial diameter, facilitating delivery. Suprapubic pressure may assist rotation. So you can see over here it is being rotated, and this somehow reduces the bis acromial diameter. So even here it is it the same thing? This is the posterior shoulder, and yeah. So rotation somehow reduces the bis acromial diameter, and with it the baby is coming out, no problems. And suprapubic pressure just like the previous one. Reverse corkscrew, it's not corkscrew, it's Wood's maneuver, Wood screw maneuver, modified reverse. Rotate the anterior shoulder in the opposite direction and release the impaction. So first we are talking about posterior shoulder, now we are talking about reverse Wood screw maneuver. So we are looking at nice image. So here it was reverse is not given anywhere. It is just the opposite. Rather than looking at posterior shoulder, which is posterior shoulder, sacral promontory related to that, we are doing it the anterior shoulder in the opposite direction to release the impaction. Rubin's maneuver: insert fingers into the vagina and apply pressure to the posterior aspect of the anterior shoulder, to reduce the shoulder diameter. So, let us take a look. Posterior aspect of the anterior shoulder. So, posterior aspect of the anterior shoulder to requires the practice to apply on the posterior surface of the posterior shoulder. No, not that. So, rotational Wood's maneuver was the first one, and suprapubic. Not that, not that. Yeah. Oh no, oh no, oh no. Let us finish this off. Let us just try to imagine Rubin's maneuver. Yeah, requires the midwife to identify posterior shoulder on vaginal exam. So, it is posterior aspect of the anterior shoulder to reduce the shoulder diameter. Rubin's maneuver, we need to go in much more detail. Let us search it somewhere. Where anterior shoulder is dislodged under pubic symphysis. Yes, anterior shoulder is dislodged. Applying pressure while in the McRoberts position. McRoberts is the flexion of that thing, flexion of this thing, knee, hip. Dislodge the anterior shoulder under pubic symphysis by applying suprapubic pressure while the mother is in McRoberts position. Everything is flexed, and clinician inserts the fingers into the vaginal canal to try to manually rotate the baby's shoulder towards their chest, reducing the diameter. So, if you can imagine, yeah, this is the one. Yeah, this one is from the top, but this is actually from inside. You can do it. Yeah, this is the nice image. This one, second one. Yeah, that was for A. Oh shit, sorry. This anteriorism, posterior aspect of the anterior shoulder is turned so that this thing comes like this. It was that simple. Yeah. Anyways, coming to the delivery of posterior arm, reach into the vagina, locate the posterior arm, flex the elbow and deliver the arm across the chest. Flex the elbow and deliver the arm across the chest. So, reach the vagina, locate the posterior arm, whatever is near the sacral promontory. Flex the elbow, deliver the arm across the chest, reducing the shoulder diameter. So, most of it we are looking at bringing it closer to the chest to reduce the bisacral diameter, either by looking at the anterior shoulder or posterior shoulder. Everything is to get it near the chest to reduce the bisacral diameter, and we have specifically named each of them. Yes, that is what. Here it is posterior, it is anterior in opposite direction to release impaction. Here it is anterior, but from the posterior aspect. Probably this is anterior from anterior aspect, reverse Wood's maneuver, and this is posterior aspect of the anterior shoulder. Everything to bring it near the chest, eventually to reduce the bisacral diameter. That is what it is. Tertiary maneuvers, Gaskin's maneuver. The mother is placed in the just take this off. We are not taking a break right now. We need to finish this. Gaskin's maneuver. So, all four position, McRoberts. Yeah, this is the one. Yes, Gaskin's. So, we can see something here. This is the place. This one. All four, widen the pelvic outline and facilitate delivery, commonly used in community settings. Zavanelli maneuver. The fetal head is pushed back into the uterus, followed by emergency C-section. This is the last resort maneuver to Z, meaning last one, last alphabet, last member of the alphabet, because alphabet is A to Z. It is not alphabets, it is alphabet A to Z, and Z is the last letter of the alphabet. Yeah, it is something like that. This is the last resort maneuver for both high risk, this one, and clavicle fracture, claviculotomy. Deliberate fracture of clavicle to reduce the shoulder width. used in dead fetuses or when other methods fail. So, break this, it is very sad. Symphysiotomy, surgical division of pubic symphysis to increase the pelvic diameter. We have seen this previously in this one too, obstructed labor. Management principles: avoid excessive traction, gentle maneuvers to reduce the risk of brachial plexus injury or clavicle fracture. Documentation: all steps and time intervals must be documented to ensure proper care and avoid litigation. Neonatal resuscitation: pediatrician should be present to manage potential asphyxia or injuries post delivery. And then postpartum hemorrhage management: monitor the mother closely for bleeding and genital tract injuries. So, again management principles: excessive traction should be avoided, despite though we are doing maneuvers and all moving stuff, better to be careful. Brachial plexus injuries can occur, so, it is present in pediatrics section, you can go through it. Brachial plexus injuries. Documentation, write it down. Neonatal resuscitation, very important. Post delivery, postpartum management. Prognosis: fetal prognosis is good if the shoulders are delivered within 5 minutes. Risk of permanent brachial plexus injury increases with delays. Neonatal mortality is rare but increases with prolonged hypoxia. Maternal prognosis: genital tract injuries and PPH are common but manageable. Psychological trauma may be not trauma. Psychological support may be needed due to the traumatic nature of the event. Yeah, so yeah, psychological trauma. Anyways, one last topic is remaining. We'll just close this off, and I think I need to end the video right now so that I can take a longer break, and I shouldn't be including that. And if I include that, it would be too much of wasted. What do you say? Wasted space. No, see, if it is a 4-hour video compared to, if it, for example, it's an 8-hour video, that's fine. If it's an 8-hour video, 4 hours plus 4 hours, it's fine. But if there is a break, 1 hour break in the middle, it becomes a 9-hour, and rather than being something like 4 GBs, it becomes 5 GB. So 1 extra GB that is being consumed in some data center somewhere, and also it might look a little bit suspicious. This guy is taking so much of extra time and placing that in the videos, is manufacturing content. Something like that. So, because of that, I'll choose to take rest privately by turning off the video. So, next is anencephaly. How much? Very short, very short. We can finish this off very quick compared to the other ones. And then PPH, little bit big, it's fine. Then we'll look at the final boss, uterine atony, and then the rest of the things. These are fine, rupture uterus and all that. And then these are all small topics. The last parts maybe somewhat. Then maybe probably next session we should cover up hopefully entire ops. Very good, very nice. Yeah, right now I'm going to end the video. In case you like this particular thing, you can like this, and in case you would like to say something about it, you can talk about it in the comments. There are no comments at all. What's happening? Anyways, I'll end the video now, and you can watch the next video after this. It is probably going to start from this one. What is it? Anencephaly. Alright then, bye bye.